Good morning. Good morning and welcome, everyone. I'm Melinda Horton, Executive Secretary of the Advisory Committee on Immunization Practices. Today is February 28th, 2024, and I am pleased to call today's ACIP meeting to order. I'll begin today by going through a few slides to provide an overview of our purpose and process this morning. Next slide, please. Welcome to the February 28th, 29th, 2024 ACIP meeting. Copies of the slides being presented at today's meeting are available on the ACIP website. A few notes on meeting logistics for those who are listening in on the Zoom line. Please keep your line muted until you're called on for discussion. When the meeting is opened for discussion, please use the raise hand function in Zoom to virtually raise your hand if you wish to be recognized. During the discussion, questions will be taken first from voting ACIP members and ex officios, and then, as time allows, from liaison representatives. Please keep your video off until we get to the votes. We will then ask those voting to turn on their video during the voting. Next slide, please. The Advisory Committee on Immunization Practices is at its heart a public body, and engagement with the public and transparency in our processes are vital to the committee's work. For this meeting, we will be holding one oral public comment period, which will occur today at approximately 1:40 p.m. Eastern Standard Time. To create a fair and more efficient process for requesting to make oral comment, we ask those interested to submit a request online in advance of the meeting. We give priority to advance requests, and if there are more requests than can be accommodated in the allotted time, we select speakers through a blinded lottery. The 7 speakers selected by lottery for this meeting have already been notified. We thank all those who requested an opportunity to make a public comment. Members of the public also had the opportunity to submit written public comments on issues coming to ACIP via regulations.gov. The docket number for today's meeting is ID CDC 2024-0001. More information on the public comment process can be found on the ACIP meeting website. Next slide, please. As noted in the ACIP Policies and Procedures Manual, members of the ACIP agree to forgo participation in certain activities related to vaccines during their tenure on the committee. For certain other activities that potentially enhance a member's expertise while serving on the committee, CDC has issued limited conflict of interest waivers. Members who conduct vaccine clinical trials or serve on data safety monitoring boards may present to the committee on matters related to those vaccines, but these members are prohibited from participating in committee votes on issues related to those vaccines. Regarding other vaccines of the concerned company, a member may participate in discussions with the provision that he or she abstains on all votes related to the vaccines of that company. At the beginning of each meeting, ACIP members state any conflicts of interest. Next slide, please. Before I begin roll call, I'm pleased to announce that new ACIP members have been approved by the Department of Health and Human Services. Official letters of invitation will be going out soon to these individuals, and we look forward to having them join us at a future ACIP meeting. As allowed under ACIP's charter, today our 6 ex officio members are being temporarily designated as voting members. During roll call and prior to the votes, I will ask that the ex officio members state any conflicts of interest. Additionally, because our chair has not yet completed the process to join the committee, I will be chairing this meeting. I will now take roll call, starting with ACIP members and then ex officio members and liaisons. For liaisons, I will announce the organization name, and then please indicate if you're present and your first and last name. For the ACIP members and ex officio representatives, I'll ask that you state your name, affiliation, and whether you have any conflicts of interest. Dr. Brooks.
Oliver Brooks, clinical professor of pediatrics, Charles R. Drew University of Medicine and Science, no conflicts.
Thank you. Dr. Chen.
Wilbur Chen, professor of medicine at the University of Maryland School of Medicine's Center for Vaccine Development and Global Health. I do have a declaration of potential conflict of interest. I'm working with Mass Biologics on a diarrhea therapeutic product that is funded by the Bill and Melinda Gates Foundation. Mass Biologics is a nonprofit vaccine manufacturer associated with the University of Massachusetts Chan Medical School and maker of a TD or tetanus diphtheria vaccine. Because this meeting will include a vote on the addition of TD to the VFC program, I will recuse myself from the VFC vote.
Thank you. Dr. Sineas?
Good morning, Sybil Sineas. I am an associate professor of medicine and pediatrics at the Warren Alpert Medical School of Brown University, and I have no conflicts.
Thank you. Dr. Daly?
Good morning, Matt Daly. I'm senior investigator, Kaiser Permanente, Colorado, and an associate professor at University of Colorado School of Medicine. I have no conflicts of interest. Thanks.
Thank you. Dr. Cotton?
Good morning, Camille Cotton. I'm the clinical director of transplant and immunocompromised host infectious diseases at Massachusetts General Hospital, an associate professor at Harvard Medical School. I have no conflicts of interest.
Thank you. Dr. Lear?
Jamie Lair. I'm a physician in private practice in Ithaca, New York, and I have no conflicts of interest.
Thank you. Dr. Long?
Good morning. I'm Sarah Long. I'm a professor of pediatrics at Drexel University College of Medicine and clinical pediatric infectious disease specialist. I have no conflict of interest.
Thank you. Next, I will call on our ex officios. Ms. Hans?
Good morning. I'm Mary Beth Hans, Deputy Director of the Division of Quality and Health Outcomes at the Centers for Medicare and Medicaid Services, and I have no conflicts.
Thank you. Captain Grimes?
It's Commander George Reed Grimes. I am the Division Director for the Division of Injury Compensation Programs at the Health Resources and Services Administration. I have no conflicts.
Thank you. Dr. Clark?
Good morning. I'm Matthew Clark with the Indian Health Service, and I have no conflicts.
Thank you. Captain Marshall?
Good morning, Valerie Marshall, Office of Infectious Disease and HIV/AIDS Policy. I have no conflicts.
Thank you. Dr. Beigel?
Good morning, John Beigel from the National Institute of Allergy and Infectious Diseases, NIH, and I have no conflicts.
Thank you. Dr. Kaslow?
David Kaslow, Director, Office of Vaccines Research and Review, US FDA, no conflicts of interest.
Thank you. And I also would like to give Dr. Daskalakis an opportunity to introduce himself at this time.
Good morning, everyone. Thank you for being here. My name is Dimitri Daskalakis, and I am the director of the National Center for Immunizations and Respiratory Diseases. Thank you for being here.
Thank you. Next, we will go through our liaison representatives. Please indicate whether you're present and your first and last name. American Academy of Family Physicians. American Academy of Pediatrics.
Jim Campbell, present.
Thank you. American Academy of Pediatrics Red Book.
David Kimberlin, present.
Thank you. American Academy of Physician Associates. American College Health Association.
Sarah Lee, present.
American College of Nurse Midwives.
Carol Hayes, present.
American College of Obstetricians and Gynecologists. American College of OBGYN. I'll try again. American College of Obstetricians and Gynecologists. American College of Physicians.
Good morning, Jason Goldman, present.
Thank you. American Geriatric Society.
Good morning, Ken Schrader, grade yes.
Thank you. Good morning. Welcome. America's Health Insurance Plans.
Good morning, Jessica Grubb, present.
Thank you. Welcome. The American Immunization Registry Association.
Good morning, Rebecca Coyle and Courtney Londo.
Thank you. Welcome. The American Medical Association.
Sandra Freithofer, representing the American Medical Association.
Thank you. Welcome. The American Nurses Association.
Barbara Resnick, present.
Good morning. Welcome. The American Osteopathic Association.
Good morning. And Masoud Mahmoudi present.
Good morning. Thank you. The American Pharmacists Association.
Good morning, welcome. The Pharmacists Association.
Good morning, Kelly Good, present.
Good morning, thank you. The the Association of Immunization Managers.
Hi, good morning, Molly Howell, present.
Association for Prevention, Teaching, and Research. Association of State and Territorial Health Officials. Biotechnology Innovation Organization.
Good morning, Phyllis Arthur and Emily Acker for Bio.
Good morning, welcome. Council of State and Territorial Epidemiologists.
Christine Hahn, present.
Good morning, welcome. Canadian National Advisory Committee on Immunization.
Matthew Timmins, present.
Good morning, welcome. Infectious Diseases Society of America. International Society for Travel Medicine.
Elizabeth Barnett, present.
Good morning, welcome. National Association of County and City Health Officials.
Matt Zahn, present.
Good morning, welcome. National Association of Pediatric Nurse Practitioners.
Good morning, Dana Deshawn, present.
Good morning, welcome. National Foundation for Infectious Diseases.
Bob Hopkins for NFID, happy to be here.
Glad to have you here, thank you. National Medical Association. Pediatric.
Good morning.
Oh.
Good morning, Patrick Lee Williams, present.
Good morning, welcome. Pediatric Infectious Diseases Society.
Grant Paulson, present.
Good morning, welcome. Pharmaceutical Research and Manufacturers of America.
Good morning, Corey Robertson, present.
Good morning, welcome. Society for Adolescent Health and Medicine.
Good morning, it's Amy Middleman representing SAM.
Thank you. Welcome. Society for Healthcare Epidemiology of America.
Preeti Mehrotra, present.
Good morning, welcome. Are there any liaison representatives who missed roll call and have now joined, who would like to identify themselves?
Good morning, Marie-Michelle Léger, American Academy of Physician Associates.
Good morning, welcome.
Good morning, Dr. Wharton. Sean O'Leary, American Academy of Pediatrics.
Good morning, welcome. So we will now move on to the first session of the day. I will turn the microphone over to Dr. Matt Daly, Chair of the COVID-19 Work Group, who will provide an introduction and overview of today's session.
Thanks so much, Dr. Wharton. So I will be introducing this session on behalf of the ACIP COVID-19 Vaccines Work Group. Next slide, please. So just to review current COVID-19 vaccine policy, we met September 12th of 2023 to review the available evidence for the updated 23-24 formula of COVID-19 vaccines. And at that time, ACIP recommended an updated COVID-19 vaccine as authorized under emergency use authorization or approved by a biologics license application in persons aged 6 months and older, including recommendations for Moderna COVID-19 vaccine in persons 6 months and older, Pfizer BioNTech COVID-19 vaccine in persons 6 months and older, and then Novavax COVID-19 vaccine in persons 12 years and older. The recommendations also included a recommendation that everyone age 5 years and older get an updated dose of the 23-24 formula to protect against serious illness from COVID-19, and this was regardless of prior vaccination or infection history. And then for children aged 6 months to 4 years, multiple doses were recommended for them to be up to date, including at least one dose of the updated 23-24 formula of COVID-19 vaccine. And then just to highlight that there were additional recommendations for those who were moderately or severely immunocompromised, among whom decisions could be made to get additional doses of the updated vaccine. Next slide, please. And then we met in October at our regularly scheduled meeting, and at that meeting, in the context of COVID-19 vaccine policy, we reviewed vaccine implementation issues, and then there were several policy updates. Next slide, please. So to review what we'll discuss today, here's our agenda. First, we'll hear from Dr. Taylor, who's going to review COVID-19 hospitalization data from COVIDnet. We'll then hear from Dr. Chatham Stevens, who will review current coverage estimates. Following this, we'll hear from Dr. Link Gellis, who will review COVID-19 vaccine effectiveness. Following this, we'll hear from Dr. Prosser, who will present on the economic analysis of an additional dose of a COVID-19 vaccine. Following this, we'll hear from Dr. Wallace, who will review evidence to recommendations framework for an additional dose of COVID-19 vaccine. And then next, we're going to hear from Dr. Panagiotopoulos, who will review next steps for the COVID-19 vaccine program, and that's sort of looking forward to plans for the 24-25 season. And then after that, we'll hear from Dr. Wallace, and this will be in the context of a vote for an additional dose of COVID-19 vaccine, and that'll be after public comment. Next slide, please. So I want to thank the work group members who've been hard at work since we last met in October, and these include ACIP member Dr. Brooks. It includes ex officio and government members, liaisons, consultants, and then my sincere thanks to the CDC co-leads who've been tremendous. That's Dr. Wallace and Dr. Panagiotopoulos. Next slide, please. And then a long and amazing group of people who contribute to the work that we do and the decisions that we make. Next slide, please. So we turn it back to you, Dr. Wharton.
Thank you. I believe our next speaker is Dr. Taylor.
Good morning. Today, I will be discussing data from the COVID-19 Associated Hospitalization Surveillance Network, or COVIDnet. Next slide, please. COVIDnet is one of 3 platforms that comprise the RESTnet surveillance system, FluServe, another RESTnet platform with very similar methods, as well as RSVnet are part of the RESTnet network. As a reminder, COVIDnet collects data from more than 300 acute care hospitals in 98 counties across 13 states. The COVIDnet catchment area includes about 10% of the US population. Hospitalizations reported to COVIDnet include all those where a positive SARS-CoV-2 test result was reported within 14 days prior or during hospitalization. Screening for SARS-CoV-2 is driven by clinical judgment and facility policies. Data on rates and basic demographic data are collected on all patients, and clinical data are collected from an age and site stratified random sample. Next slide. And next slide, please. So this slide shows 2 figures. The left figure shows the weekly rates of COVID-19 associated hospitalizations among all adult age groups from March 2020 through January 2024. The figure on the right in the red box is at the same scale as the figure on the left, but only includes data from the most recent 4 months of October 2023 through January 2024. Since March 2020, rates in adults ages 65 years and older, and especially those ages 75 years and older, were higher than all other adult age groups. Next slide. This chart shows the percent of COVID-19 associated hospitalizations by age group. Adults over 65 years and older are shown in blue. Younger age groups are shown in gray. Over time, the proportion of hospitalizations has shifted, and the majority of hospitalizations are among those 65 years and older. For the current respiratory season, starting in October 2023 and going through January 2024, highlighted by the red box, adults ages 65 years and older comprised 67%, or 2/3, of all hospitalizations captured in COVIDnet. Adults 75 years and older comprised 46% of hospitalizations, or almost half. Next slide, please. This slide shows the percent of COVID-19 hospitalizations that occurred among adults 75 years and older who resided in a long-term care facility at the time of admission. The percent of adults ages 75 years and older residing in a long-term care facility varies from month to month from 13 to 32% for October 2022 through November 2023. For that period, 25%, or 1 in 4, adults aged 75 years and older hospitalized with COVID-19 resided in a long-term care facility. Next slide. This figure shows the percent of COVID-19 hospitalizations that resulted in in-hospital death. Among all adults hospitalized with COVID-19 for the period of October 2022 through November 2023, 3.8% died in hospital. 1.4% of adults aged 18 to 49 years hospitalized with COVID-19 died in hospital. The highest proportions of in-hospital deaths occurred among adults 65 years of age and older, with 5.5% of adults 65 to 74 years and 4.4% of adults 75 years and older dying in hospital. Note that the sample sizes shown are unweighted counts. Among adults 65 years and older who died in hospital, 28% were residents of a long-term care facility. Additionally, as noted in the footnote, an ongoing analysis of death certificate data from March 2020 through April 2022 has found that while 67% of deaths occurred in hospital, 33% of deaths occurred within 30 days post-discharge, and the proportion of deaths occurring post-discharge increased with age. Next slide, please. This figure shows the percent of COVID-19 associated hospitalizations among persons with an immunocompromising condition for all adults and by age group. For the period of October 2022 through November 2023, 16% of all adults hospitalized with COVID-19 had an immunocompromising condition. These percents varied by age, ranging from 12%, or 1 in 8 adults ages 18 to 49 years, to 21%, or 1 in 5 adults ages 65 to 74 years with an immunocompromising condition. Next slide. This figure shows the proportion of COVID-19 associated hospitalizations among adults by immunocompromised status overall and by intervention or outcome for October 2022 through November 2023. Starting with the left column, 16% of all COVID-19 associated hospitalizations were among persons with an immunocompromising condition. Among those admitted to the ICU, 17% had an immunocompromising condition, and 28% of those who died in hospital had an immunocompromising condition. Next slide. This table shows the prevalence of categories of underlying conditions among COVID-19 associated hospitalizations in adults by age group. The 4 most prevalent conditions among hospitalized adults within each age category are highlighted in pink, with the darkest shade of pink for the most common condition in each group. Among adults ages 18 to 49 years, the most common underlying condition is obesity. Among adults 50 years and older, the condition with the highest prevalence is cardiovascular disease. Chronic lung disease, cardiovascular disease, diabetes, and obesity have some of the highest prevalence in most age groups. Among adults 75 years and older, neurologic conditions, including dementia, is the second most prevalent condition after cardiovascular disease, followed by diabetes and chronic lung disease. Next slide, please. This figure shows the proportion of COVID-19 associated hospitalizations by vaccination status among adult age groups for October and November 2023. Data are limited to these 2 months as they are the 2 months of data available where we have data on the updated 2023-2024 monovalent dose. The percent of hospitalized adults who had no record of receiving either the bivalent or the updated 2023-2024 monovalent COVID-19 vaccination is indicated in gray and comprises most hospitalizations. Adults who received a bivalent COVID-19 vaccination, but not an updated 2023-2024 monovalent dose are indicated in yellow. Those who received an updated monovalent dose are shown in green. Overall, no more than 5% of hospitalized adults in any age category received the updated 2023-2024 monovalent dose. The largest proportion of hospitalized adults who received the updated monovalent dose was adults ages 65 years and older, with 5%. Please note that these data are preliminary, as they only include 2 months of hospitalization data for which the updated monovalent vaccine dose was recommended. Continued examinations of these data remain ongoing. And I believe the next slide is my acknowledgement slide, which is my final slide, and I'm happy to take any questions. Thank you.
Thank you. I think we'll hold questions until after the next presentation.
Thank you.
Dr. Chatham-Stevens?
Great. Good morning, all. Kevin Chatham-Stevens here. Can we go to the next slide, please? While that's coming up, I'm the Immunization Services Readiness and Response Lead, and so I'll be presenting some of the COVID-19 vaccination coverage data. Excellent, great, thank you. Can we go to the next slide, please? So I'll be providing an update, like I said, on the COVID-19 vaccination coverage data first, and then followed by attitudes and experiences regarding COVID-19 vaccination following that. So next slide, please. Okay. So starting off here, we have the percent of adults 18 years and older on the left, and the percent of children 6 months through 17 years on the right, reported to be up to date with the 2023-24 COVID-19 vaccine through February 3rd. These data come from the National Immunization Survey, which is an ongoing random digit dial cell phone survey of households. All of the estimates on this slide are based upon self-report of vaccination in the month of that vaccination. So among adults overall, 21.9% reported being up to date, with a range from 43.5% among those 75 years and older, down to 9.5% among those 18 to 29 years. Among children overall, 12.2% were reported to be up to date, with a range from 15.8% among those 12 to 17 years old, down to 5.9% among those 6 months through 4 years. Next slide, please. So here we see COVID-19 vaccination coverage among adults by jurisdiction, once again from the National Immunization Survey, ranging from 9.5% in Puerto Rico and 10.5% in Mississippi to 41.9% in DC. Next slide, please. So this slide shows the percent of adults who were vaccinated with the 2023 to 24 COVID-19 vaccine in dark blue, gradually rising from about 3% in late September to 21.9% as of February 3rd. The percent of adults reporting they definitely will get vaccinated in royal blue decreased from 28.2 to 11.3%. In light blue, you'll see the percent of adults reporting they probably will get vaccinated or are unsure if they'll get vaccinated has remained relatively stable between approximately 27 to 32%. And in salmon, the percent reporting they probably or definitely will not get vaccinated has also remained relatively stable between 37 to 42%. Next slide, please. So the following two slides provide some of the demographics of survey respondents from this time period, so December 31st through January 27th. Next slide, please. So looking at these data through late January, 20.9% of adults reported receiving the updated COVID-19 vaccine, with coverage among females higher at 23.2% than males at 18.6%. Also, coverage varied by race ethnicity, with coverage highest amongst white non-Hispanic adults at 24.4%, and lowest among American Indian, Alaska Native at 11.4%, Native Hawaiians and other Pacific Islanders at 14.1%, and Hispanic adults at 13.3%. Next slide, please. Here we see coverage by other variables, including urbanicity, with coverage in rural areas at 16.8%, being lower than coverage in suburban and urban areas at 21.3% and 29.9% respectively. Adults with health insurance at 22.7% had higher vaccination coverage than adults without health insurance at 6.9%. Coverage also varied by household income, with coverage increasing with increasing income. Those with incomes greater than $75,000 had the highest coverage at 26.1%. Coverage did not vary based on disability status. Next slide, please. So this slide shows the percent of pregnant persons 18 to 49 years old who were vaccinated with the 2023 to 24 COVID-19 vaccine. These data come from the Vaccine Safety Data Link, which is a collaborative project between CDC, integrative healthcare organizations, and networks across the US that uses electronic health data from participating sites to monitor and assess the safety of vaccines. Overall, 12.5% of pregnant persons received an updated COVID-19 vaccine as of January 27th, with coverage ranging from 4.8% among Black non-Hispanic persons to 21.3% among Asian persons. Next slide, please. So like I said, now I'll transition a bit and present some of the findings about attitudes and experiences regarding COVID-19 vaccine. Next slide, please. So here we have the most frequent COVID-19 vaccination concerns among adults, categorized by their vaccination status or intent to get vaccinated. With those who received the vaccine or definitely will get the vaccine on the left, those who probably will get the vaccine or are unsure if they'll get the vaccine in the middle, and then those who probably or definitely will not get the vaccine on the right. These data, January data, are from the CDC Omnibus Survey, which is a survey of a nationally representative sample of US adults used for the rapid collection on receipt, intent, knowledge, attitudes, beliefs, and behaviors related to COVID-19 vaccination. Next slide, please. So among those who received the vaccine or definitely get the vaccine, most at 74.1% had no concerns, and the most common concern was mild side effects at 10.1%. Next slide, please. Among those who probably will get the vaccine or are unsure, 40.7% had no concerns, and the most common concern was unknown serious side effects among 15.5%. Next slide, please. And among those who probably or definitely will not get the vaccine, the most common concern was unknown serious side effects at 47%. Next slide, please. So then next, we're really going to focus in on those adults who reported effectiveness as a concern. Next slide, please. So this slide shows the specific concerns about effectiveness among those who reported effectiveness as a concern on the preceding slide. As you can see, the most common concern was will not prevent getting sick at 77.3%, followed by may not be effective against new variants at 67.6%, will not prevent infecting others at 52.4%, and will not prevent serious illness at 45.7%. Next slide, please. So here we have findings on how people think and feel about COVID-19 vaccines, comparing results from January 2022 to results from January 2024 from the National Immunization Survey. Next slide, please. So first, on the left, we see the percent of US adults who think that a COVID-19 vaccine is very or completely safe has declined from 67.3% to 55.6%. Next slide, please. Then in the middle, the percent of US adults who think that a COVID-19 vaccine is somewhat or very important has declined from 83.9% to 69.6%. Next slide, please. And on the right, the percent of US adults who are moderately or very concerned about getting COVID-19 has declined from 55% to 32.7%. Next slide, please. So now I'll show some results regarding healthcare provider COVID-19 vaccine recommendations. On the left, we have data from the National Immunization Survey, so once again, a survey of patients, not of healthcare providers, showing that the percent of adults reporting that their healthcare provider recommends the COVID-19 vaccine decreased from 36.1% in May 2021 to 20.4% in January 2024. And then on the right, we have data from a CDC-RAND University of Iowa survey of healthcare providers from February 2023. So this survey involves a panel of healthcare providers, including all physician specialties and other health-related professions, such as nurses and pharmacists. The results here for physicians who spend at least half of their time in outpatient primary care, and vaccines are administered at their work site. As you can see, most physicians reported they always recommend bivalent boosters, with the percentage being highest for patients 65 years and older at 80.9%. Next slide, please. So keeping with that CDC-RAND University of Iowa survey from February 2023, here are the reasons that healthcare providers reported for not recommending the COVID-19 bivalent boosters to eligible patients. Please note that this slide now includes data from physicians, nurses, and pharmacists. While the most common reason was a medical reason for not recommending the COVID-19 vaccine, 3 of the top 4 reasons included patient will refuse booster vaccination, patients tired of hearing about COVID-19 vaccines, and high level of vaccine resistance in the community. Next slide, please. So those were the reasons that healthcare providers may not recommend the vaccine, but what about potential reasons for providers to not stock the vaccine? So here on this slide, we've listed some of the potential reasons why primary care providers may not carry or stock the COVID-19 vaccines. We've heard from some providers that there's low interest for COVID-19 vaccination in their patient population or the broader community. This was also reflected in a couple of the responses on the previous slide. And now that the COVID-19 vaccine has been commercialized, cost of the vaccine and other associated vaccination costs may be a barrier as well. Some healthcare providers may want to carry the vaccine, but their healthcare system that they're a part of has decided to not carry the vaccine and refer patients elsewhere. And some providers may see the availability of the COVID-19 vaccines elsewhere in the community, such as at pharmacies and other clinics, and decide it's not needed for them to stock the vaccines themselves. Next slide, please. Having said that, fewer Americans are now reporting difficulty in getting the COVID-19 vaccines, with the percent of US adults reporting no or little difficulty in getting a COVID-19 vaccine on the left, increasing from 80.5% in May 2021 to 95% in January 2024. And on the right, we see that most Americans reported little to no difficulty in getting a COVID-19 vaccine across income ranges in October 2023. Next slide, please. And finally, here's some data from the omnibus surveys from late last year on the acceptability of co-administration of the flu, COVID-19, and RSV vaccines. Respondents were asked if you were due for them and they were offered, would you get more than one of these vaccines in the same visit? COVID-19, flu, RSV. As you can see, approximately 2/3 of US adults indicated they would be open to co-administration of these vaccines. Next slide, please. I'd like to acknowledge these people and others for help in developing and reviewing these slides. Thank you very much.
Thank you very much, Dr. Chatham-Stevens. We now have a few minutes where we can take questions for either Dr. Taylor or Dr. Chatham-Stevens on either of these presentations. Thank you. Are there any questions from the committee? Dr. Daly?
Dr. Chatham-Stevens, thanks so much for that. I want to ask about racial and ethnic disparities in uptake of 23-24 formula. And this is in the context of, recognizing that low coverage overall is the biggest problem, but it feels like some disparities have returned, and I'm just seeing if you interpret it the same way and also if you have some sense of why.
Sure, thanks for that question. So, yeah, I think if you look at the coverage data overall, like I presented for adults, there were some racial ethnic disparities, and then also amongst pregnant people, we've seen some racial ethnic disparities, right? And I That's not necessarily unique to the COVID-19 vaccine, unfortunately. We see some of those similar disparities throughout other vaccines, right? And so some of that is maybe reflect disparities in access to vaccine, right? Access to healthcare. There are, the mis and disinformation that is circulating in different populations may vary as well. So we think there's probably multiple reasons why we're seeing some of these disparities that we saw before COVID that were mitigated to some degree during the height of the federally distributed COVID-19 vaccine program. We've seen some of those kind of start to return. And so I think just to take a step back, I want to kind of lay out some of the activities that CDC is engaged in to kind of address some of these issues. So if you can kind of visualize a pyramid, at the bottom of that pyramid, we have our kind of routine day-to-day work that occurs across CDC in optimizing the vaccine landscape, right? That's VFC, that's the 317 program, work on IISs, the National Immunization Survey, work with healthcare providers. So that's the core, the base of our healthcare, of our vaccine landscape. And then you layer on top of that the Let's Rise program, right? That was specifically launched to help address some of the disparities and some of the losses in vaccine coverage that we saw because of the height of the COVID-19 pandemic, right? And that's, involves a whole bunch of different activities, communications campaigns, toolkits, working closely with healthcare providers and jurisdictions. And then you layer on top of that all the vaccine equity work, right? For example, the Partnering for Vaccine Equity program, which has funded a large number of community-based organizations, healthcare providers, and others to really get out there and try to address some of these disparities in adult vaccinations. And then also we have ongoing work to try to identify, populations that may be disproportionately affected by vaccine-preventable diseases, as well as communities that may be at increased risk for outbreaks of vaccine-preventable diseases. So I think we're trying to address it broadly because we know this is an issue across vaccines, and then narrow it down as much as possible for specific vaccines. And for example, obviously the Bridge Access Program is a large COVID-19 focused program, really trying to make sure that we're addressing some of those disparities amongst uninsured populations.
Great, thank you. Dr. Lear?
I'd like to take a second to speak to the primary care physicians of the country. COVID vaccine now is just a regular vaccine like we have for everything else. And I totally acknowledge that lots of people don't want it. But since I've had it in my office, I regularly have 2 or 3 people a day who say, oh, I can get it here? That's great. And they're very pleased to make it easy. Anything we can do to lower the barrier of getting a vaccine in someone's arm is just wonderful. So I just treat this like the flu vaccine and like everything else. It's a vaccine that I offer to my patients. And yes, some people don't want it, but a lot of people are glad that I have it in my office. So thank you.
Thank you. Dr. Long.
A question for Dr. Taylor's presentation. I don't know what we are meant to do with the data that you presented, but as on all of our work groups, we're looking at age versus risk categorization of recommendations. It's difficult to interpret the slide on hospitalized patients and the percent who had this and that condition without knowing the population at large with this and that condition in the same age group. So for instance, we might all jump on obesity. There's probably being a risk for hospitalization, as we've seen that previously in studies in certain age groups. But if we just look at dementia, the dementia that increases with the population over 75 is almost surely just a marker of age and conditions in the general population. In addition, the data on the immunocompromising conditions that people have, it didn't look too different than we have seen for the population at large in our RSV work group. It might have been a little bit higher, but unquestionably, the fact is the fact that there was greater death in hospital if one was immunocompromised. So I don't know if you're meant to lead us to think these are risk conditions for hospitalization without the accompanying kind of control data.
Thank you for that. Yes, and we do acknowledge that that is a limitation. Early on in the pandemic, there was an analysis that was published that paired COVID-19 data from the early months of the pandemic through June 2020 with population level underlying conditions that were available through the Behavioral Risk Factor Surveillance System, or BRFSS, which provides estimates of underlying chronic conditions at a population level. And that paper was published looking at those risks of hospitalization versus the risk in the population. We are working to update that analysis, and we anticipate that that presentation will be ready for the next ACIP meeting. So thank you. We do acknowledge that limitation. I will note that that analysis regrettably cannot include immunocompromising conditions. That's not something that we have population level data on through our available sources like NHANES or BRFSS. But the conditions that are captured in BRFSS will be included, and we look forward to sharing those results with the work group and the committee.
Thank you. Dr. Brooks?
Yes, first of all, excellent presentations ×2. Just a quick comment. We've received a lot of information. We have to figure out what's the synopsis. Income reduces coverage. Insurance status reduces coverage. Only 5% of Black pregnant women got vaccinated. Why? Lower rates among African Americans. Why? So that's our job, to take this and make something of it. So my question is for Dr. Jatham Stevens. So there was the only graph that showed anything geographic was the one with state coverage. So do you have any data on urban versus rural? Because we've often seen a great disparity in immunization coverage based on that.
Yes, on one of the slides that I did present, there is the breakdown, and once again, this is from National Immunization Survey data on urban versus rural. And let me just see if I can pull that up. Yeah, so amongst the NIS respondents, and this is slide number 6, if you can pull that up, urban and suburban respondents. Can you go forward 2, please? There we go. Excellent. Thank you. So yeah, amongst urban and suburban residents, they had 21.9 and 21.3% coverage compared to rural respondents at 16.8%. And we do have some additional coverage maps on COVID VaxView as well, including some of the IIS data as well. So I showed, the map that I showed was NIS specific, but we also have IIS data as well online.
Thank you.
Dr. Cotton?
Thank you for sharing this excellent data. It is devastating to see how many elderly and then immunocompromised are being admitted to hospital, are in the ICU, and are dying from COVID-19. It is shocking to see that only 30 to 40% of the higher risk populations, at least for elderly, and I think it's a similar number for immunocompromised, are getting the updated vaccine. I would encourage at this meeting that we provide clarity on the recommendation for an updated vaccine. And for immunocompromised, in September, we said that they could get 2 doses of vaccine at least 2 months apart. But I think we really need to provide the community with clarity on that, because people don't understand what that recommendation means. And for me, this is a life and death situation for many of the patients that I take care of. Thank you.
Thank you, Dr. Cotton. Are there any other questions or comments from the committee? Okay, so we will move on to our next presentation. Dr. Link Gellis will share with us data on COVID-19 vaccine effectiveness. Dr. Link Gellis?
Good morning. My name is Ruth Link Ellis. I'm the Vaccine Effectiveness Program Lead at CDC for COVID-19. Next slide. So it's been a while since we've discussed methods for assessing vaccine effectiveness in depth. I'll start off today with a brief refresher on VE. I'll then provide some context for interpreting results and then share CDC's current data on VE of an updated 2023-2024 COVID-19 vaccine against symptomatic SARS-CoV-2 from the ACIP program, COVID-19 associated emergency department and urgent care visits from CDC's Vision network, and COVID-19 associated hospitalization from the Vision and Ivy networks. Next slide. There are a number of study designs used for vaccine effectiveness, but the most common for the COVID-19 VE has been the test negative design, or TND. In a TND, everyone who meets a clinical case definition, in this case persons with COVID-19-like illness, are enrolled, and those who test positive for the disease of interest, in this case SARS-CoV-2, are classified as cases, while those who test negative are classified as controls. Finally, vaccine status between cases and controls is compared. This means that enrollment isn't based on test status, but based on clinical case definition. Data can be ascertained through electronic healthcare records or based on clinician-ordered testing, or based on active enrollment and swabbing of persons meeting the clinical case definition. VE is then calculated as 1 minus the adjusted odds ratio times 100%, with an adjusted odds ratio comparing the odds of vaccination among cases and controls. Next slide. There are a number of benefits of the TND. First, the TND reduces bias from healthcare-seeking behavior by including cases and controls with similar symptoms who presented to care and received testing, usually at the same facility. Second, TNDs are an efficient use of a surveillance system because cases and controls are identified through the same system rather than needing one system for cases, for example, a hospital, and another for controls, for example, random digit dialing. There are also a couple of considerations for TNDs. First, they're dependent on the sensitivity and specificity of diagnostic testing and can be particularly impacted by decreases in test specificity, which can result in truly negative individuals testing positive and being misclassified as cases. Second, because vaccination behaviors for different diseases can be correlated, controls who are positive for another vaccine-preventable disease can bias results. For COVID-19, it can be helpful to consider if the exclusion of RSV positive or influenza positive controls meaningfully changes estimates. Next slide. Finally, it's helpful to keep in mind that vaccine efficacy and effectiveness are population-level estimates. If a vaccine has a VE of 80%, it does not mean that the vaccine will only work 80% of the time. It does mean that in the vaccinated population, 80% fewer people will contract the disease when they come in contact with the virus. Next slide. Okay, so this is an update to a slide we've shown previously, but I wanted to provide a reminder on interpretation of the results I'll share today. By July through August of 2023, just before the updated vaccines were introduced, individuals in the US had high rates of infection-induced immunity, above 70% for all age groups and almost 90% for those aged 16 to 49 years. Infection can provide some protection from future infection, and VE findings should therefore be interpreted as the incremental benefit provided by COVID-19 vaccination in a population with a high prevalence of infection-induced immunity. Next slide. Before diving into the VE estimates, a note here on what the studies presented today evaluated. Previously, for COVID-19, we presented results as absolute or relative VE. Absolute VE compares the frequency of health outcomes in vaccinated versus unvaccinated people. For example, those who received an updated monovalent dose versus no COVID-19 vaccine received ever. Relative VE compares the frequency of health outcomes in people who received one type of vaccine to people who received a different vaccine, or compares people who received more doses to those who received fewer doses. For example, people who received an updated monovalent dose compared to those who received a bivalent dose. This year, COVID-19 VE studies have largely shifted to looking at a combination of absolute and relative VE. Today, I'll present estimates of VE comparing those who received updated 2023-2024 doses to those who did not receive updated 2023-2024 doses, regardless of past vaccination. In other words, the comparison group includes people who were unvaccinated, as well as those who received original monovalent and bivalent doses. Next slide. I'll first share VE against symptomatic SARS-CoV-2 infection from the Increasing Community Access to Testing, or ICAT program. Data shared today represent updates to analyses published in MMWR at the beginning of February. Next slide. ICAT includes data from nationwide community-based drive-through SARS-CoV-2 testing via pharmacies. Vaccine history is self-reported at the time of test registration, and analyses used a TND. For this analysis, we included adults aged 18 and up with one or more COVID-19-like symptom and testing via nucleic acid amplification, or NAT. We excluded adults who reported immunocompromising conditions and those who reported a positive SARS-CoV-2 test in the preceding 90 days. The full analysis shared today includes an extra month of data beyond the MMWR and includes tests through February 18th, 2024. A sub-analysis using S-gene target failure as a proxy for BA.2.86 and JN.1 infection included tests from October 27, 2023 through February 15, 2024. Next slide. Here we see results from the full analysis with people 18 and up included in the top block and split by age group 18 to 49 years and 50 years and up on the bottom. VE is shown comparing receipt of an updated 2023-2024 dose to no receipt of an updated dose by time since vaccination, 7 to 59 days and 60 to 119 days. In the second column from the right, note the median time since receipt of the last dose, which was almost 2 years for younger adults and almost 1.5 years for older adults. VE for the full period was around 50%, with some evidence of decreasing VE with longer time since vaccination in younger adults. There were less tests in the older adults, and therefore confidence intervals were wider. Next slide. As mentioned, we were able to use S-gene target failure as a proxy for infection with BA.2.86 and JN.1 sublineages. This graph shows estimated proportions of SARS-CoV-2 S-gene target results and variant proportions in red and blue from genomic surveillance. The red indicates S-gene target presence, or likely XBB lineages, while the blue shows S-gene target failure, or likely BA.2.86 and JN.1 lineages. The black line shows the proportion of S-gene target presence from ICAT data, which tracks the proportion via genomic surveillance closely, indicating that S-gene target failure is a good proxy for BA.2.86 and JN.1. The proportions deviate slightly in the most recent weeks when there was relatively little ICAT testing. Next slide. This slide shows results of the sub-analysis using S-gene target failure. Because of the timing of emergence of JN.1, there was not statistical power to estimate VE in the 7 to 59 days after vaccination. So here we show only the 60 to 119 day period. The estimate on the top shows S-gene target presence, or likely non-JN1 lineages, with a VE point estimate of 60%, and the estimate on the bottom shows S-gene target failure, or likely JN.1, with a VE point estimate of 45%. Note that while the point estimates differ, the confidence intervals between the estimates overlap. Next slide. Moving on now to estimates against emergency room visits and urgent care visits from the VISION network. These data will be published in an MMWR tomorrow. Next slide. VISION is a multi-site network of electronic healthcare records using a test-negative design. This analysis included adults visiting one of 369 emergency departments or urgent cares, or 229 hospitals with COVID-like illness, and a SARS-CoV-2 NAT test result within 10 days before to 72 days after the encounter. Cases were patients with a positive NAT for SARS-CoV-2 and no positive NAT for RSV or influenza. Controls had a negative SARS-CoV-2 test and no positive influenza test. Vaccination is documented by electronic healthcare records and state and city registries. Next slide. As before, this slide shows results from adults aged 18 and up in the top. Results are separated into age groups 18 to 64 and 65 plus years on the bottom. And as before, we show VE split by 7 to 59 days and 60 to 119 days since the updated dose. In the 18 plus group, where we have the most power, VE was 51% in the 7 to 59 days post-dose and 39% in the 60 to 119 days post-dose, with non-overlapping confidence intervals. The same trend was apparent in both age groups, though CIs overlapped. VE was similar for 18 to 64-year-olds and for those 65 plus. Next slide. Now we'll move on to results from the VISION and IV networks for VE against hospitalization. These will also be included in the MMWR release tomorrow. Next slide. Starting with VISION results and as with previous results slides, we have VE for 18 plus on the top and split by age group on the bottom, with the results shown by time since dose. VE was 53% for 18 plus in the first 7 to 59 days after the dose and 50% in the 60 to 119 days after the dose, with overlapping confidence intervals. Note that due to both lower vaccine uptake and lower hospitalization rates, CIs for the 18 to 64 group were wide, particularly in the longer time since dose strata. More time will be needed to assess waning against hospitalization. Next slide. Moving on now to the IV network, a multi-site VE platform that uses case-control data, that uses a case-control design with prospective enrollment at 26 hospitals. Participants were adults hospitalized with COVID-like illness. Cases have a SARS-CoV-2 positive NAT or antigen test with no positive influenza or RSV test. Controls are negative for SARS-CoV-2 and influenza by NAT. Vaccination history is ascertained through electronic medical records, state and local vaccine registries, and self-report, and specimens are collected for central testing and sequencing. Next slide. Here results are split by 18 plus and 65 plus. Note that IV analyses did not have statistical power to estimate VE separately for adults aged 18 to 64 years or by time since dose for any age group. VE for the 7 plus days since a dose was 43%, a median of 47 days after the dose, and for those 18 plus, it was 48%, a median of 48 days after the dose for those 65 plus. Next slide. So in conclusion, updated 2023-2024 COVID-19 vaccination provided increased protection against symptomatic SARS-CoV-2 infection and COVID-19 associated ED/UC visits and hospitalizations compared to no updated vaccine dose. Receipt of an updated dose provided protection against JN.1, the most common circulating variant currently, as well as other circulating variants. Finally, these are relatively early estimates from all 3 VE studies with no substantial waning. However, waning is expected based on past experience with COVID-19 vaccines, and CDC will continue to monitor VE. Next slide. I'd like to thank the many investigators who contributed to these analyses, including VISION and IV site investigators, as well as the many CDC staff. Thank you.
Thank you, Dr. Link-Ellis. I'll ask the ACIP members and ex officios to please make note of their questions, and we'll take questions after the next presentation. Dr. Prosser, Dr. Lisa Prosser will now present on an economic analysis of additional dose of COVID-19 vaccine. Dr. Prosser?
Good morning. I'm Lisa Prosser from the University of Michigan, and thank you for the opportunity to present results of an economic analysis of an additional vaccine dose to prevent COVID-19 illness in adults. Next slide, please. I'd like to start by thanking our research team, which includes collaborators from the CDC and the University of Michigan who have worked together to contribute to this analysis. Next slide, please. We do not have any conflicts to report. Next slide. The original aims of this study, as presented in the September ACIP meeting, remain the same for the overall analysis and are listed in the first few bullets. In this second phase of the analysis, we have made 2 important updates to the model. to revise the probability of hospitalization to reflect more recent lower rates, and to adjust vaccine impact for seasonality. We have also added a new intervention strategy, which includes an additional dose of vaccine approximately 6 months following an initial dose, referred to as the 2-dose strategy. Next slide. In the next few slides, I'll review the updates to hospitalization rates and vaccine impact. Other modeling assumptions remain the same as in the September analysis. Additional details are included in the supplementary slides. This slide, as we've just seen in previous presentations, shows weekly rates of COVID-19 associated hospitalizations by season and how rates have been declining. In the first phase of this analysis presented in September, we used hospitalization rates from the first 6 months of the 2022-2023 season to derive an annualized rate. In the second phase of the analysis, we have updated these hospitalization rates to include COVID-net data from the second 6 months of the 2022-2023 season. Next slide, please. The figure on the left shows the difference in rates between the September 2023 model in blue and the current updated analysis in gray. So you can see rates are lower for the updated analysis for all age groups. The table on the right lists the updated inputs used in this analysis for base case and upper and lower bounds. Next slide. In the next few slides, I'll present the approach to adjusting for seasonality to better reflect vaccine impact over the course of a year. The panel on the left shows data on effectiveness against hospitalization for the bivalent booster from the first phase of the study. For this, as a reminder, for this approach, we use data from Vision and Ivy combined for the 180 days following vaccination, then assumed linear waning from 180 days until the end of the year. The figure on the right depicts how seasonality has been incorporated into the estimation of vaccine impact. The top line with the triangle shows hospitalizations by month, and the blue area represents hospitalizations averted by month, applying the VE waning function on the left to monthly hospitalization rates. Adjusting for seasonality yields a slightly higher vaccine impact that compared with the first phase of the analysis. Next slide, please. This slide shows seasonality adjusted impact for the 1-dose strategy for hospitalization on the left, critical illness on the right. Next slide. This slide shows seasonality adjusted impact for the 2-dose strategy. So cases averted from the initial dose of vaccine are shown in the dark blue shaded areas, and incremental cases averted with an additional dose administered approximately 6 months following the initial dose are shown in the light blue shaded areas. Again, seasonality adjusted vaccine impact for hospitalization is shown on the left and for critical care on the right. Next slide. This slide summarizes the seasonality adjusted vaccine impact for the 65 and older age groups in the right-hand panel. As a reminder, in the first phase analysis, pooled estimates were used for all adults 18 and older. On the right-hand panel, we'll be focusing primarily on the age group 65 years and older. Additional age groups are shown in the supplementary slides. In general, the seasonality adjusted vaccine impacts higher than in the previous analysis. Next slide, please. The 2-dose strategy also included updated assumptions for adverse events and costs of vaccination. These reflected probabilities and costs, double those for the 1-dose strategy. Those details are included in the supplementary slides. Next slide, please. In this presentation, we'll provide updated results of the base case analysis, incremental cost effectiveness ratios, or ICERs, comparing an updated mRNA booster 1-dose strategy to no booster, using the updated hospitalization and seasonality adjusted vaccine impact inputs. As a reminder, the ICER measures the additional investment in vaccination or cost savings associated with a change in health benefits and accounts for offsets due to averted illness. This analysis will also provide ICERs for the base case and uncertainty analyses comparing 1-dose, 2-dose, and no booster vaccination strategies. Uncertainty analyses will explore the robustness of the results to changes in input parameters. Updated results for disaggregated health and economic outcomes are included in the supplementary slides and will not be presented here. Next slide. Moving on to results. Next slide, please. Updating the model to include revised hospitalization rates and seasonality adjusted vaccine impact yields slightly higher ICERs for all age groups shown in the right-hand column compared to the September 2023 analysis. The ICER for the one-dose strategy for 18 to 49-year-olds is now roughly $163,000 per quality. For the 50 to 64-year age group, about $80,000 per quality adjusted life year gained. And for individuals 65 years and older, one dose of an updated vaccine is no longer cost saving, but yields an ICER of about $12,000 per quality adjusted life year. Next slide. This slide shows the ICERs adding this strategy for an additional dose delivered roughly 6 months following an initial dose. For the 2-dose strategy, the ICER is greater than $1.3 million per quality for the 18 to 49 age group, greater than $700,000 per quality for the 50 to 64-year-old age group, and $255,000 per quality for the 65 and older age group using base case assumptions. Next slide, please. This slide presents the results of one-way sensitivity analysis varying the probability of hospitalization to upper and lower bounds. Even using the upper bound of the probability of hospitalization, ICERs for the 18 to 49 age group remain greater than $800,000 per quality, and for the 50 to 64-year-old age group, greater than $300,000 per quality. Other sensitivity analyses show similarly unfavorable results for the 2-dose strategy in these 2 younger age groups. These are available in the supplementary slides. The next few slides will focus primarily on sensitivity analyses for the 2-dose strategy in individuals 65 years and older. Next slide, please. In the next few slides, I'll present assumptions and results for some alternative season scenarios. So this slide shows the 3 alternate scenarios. First, on the left-hand panel, the base case, which represents the observed seasonality within the 2022-2023 season. And then 2 alternate scenarios. Alternate number 1, which includes a higher peak in the winter, but roughly the same pattern of seasonality. And alternate 2, which shows a peak later in the year in the spring. Next slide. Using the same approach to derive seasonality-adjusted vaccine impact, estimates for 1-dose and 2-dose strategies are shown in the table at the bottom for a hypothetical scenario that is depicted in the upper left-hand figure. So this is for alternate season scenario 1, and base case and lower and upper bounds for seasonality-adjusted vaccine impact are shown in the table below. Next slide, please. This slide shows seasonality-adjusted vaccine impact for an alternate season with a peak in the spring. Overall, this scenario would yield higher incremental vaccine impact for a second dose because of the timing of the additional dose closer to a spring peak. Next slide, please. ICERs from these 3 seasonality scenarios are shown in the table. The ICERs are less favorable for the 1-dose strategy in the alternate scenarios because the initial dose is less closely aligned with the peak of the season. ICERs for a 2-dose strategy for 65 and older are more favorable at $199,000 per quality and $116,000 per quality in the alternate scenarios. Next slide. Varying the probability of hospitalization has a substantial impact on the results. For probability of hospitalization on the right-hand side of the table, from 2 to 4 times the base case, the incremental cost-effectiveness ratios drop to $120,000 per quality, $65,000 per quality, and $34,000 per quality. And these higher rates correspond to conditions listed in the footnote at the bottom of the table, including hypertension, diabetes, and chronic kidney disease. Next slide, please. Lower costs of vaccination are also associated with lower incremental cost-effectiveness ratios. The table at the top of the slide varies only the cost of the vaccine dose and would move a 1-dose strategy into the cost-saving range for cost per dose of $20 or $60 per dose. The ICER for a 2-dose strategy would fall below $150,000 per quality for a cost per dose at $60 or less. In the bottom table, varying all vaccination-related costs to lower bounds yields cost savings for a 1-dose strategy and $51,000 per quality for the 2-dose strategy. Next slide, please. The same set of limitations applies from the first phase of the modeling, and I won't read through these in detail, but I will note an additional limitation for the second phase of the analysis is a lack of data yet to estimate seasonality. So we've included hypothetical scenarios in this analysis. Next slide, please. In summary, the results for a one-dose strategy using updated inputs for hospitalization and seasonality-adjusted vaccine impact were as follows. Vaccination averts substantial morbidity and mortality as demonstrated through estimated disaggregated outcomes shown in the supplementary slides. ICERs for 50 to 64-year-old age group and 65 and older age groups remain robust to changes in parameter inputs across plausible ranges. The ICERs for the 18 to 49-year-old age group remain sensitive to changes in parameter inputs, more favorable for higher vaccine impact, higher risk of hospitalization, and critical illness. Results for a two-dose strategy were not economically favorable for the 18 to 49-year-olds or 50 to 64-year-old age groups across plausible parameter ranges. For the 65-year and older age group, ICERs are sensitive to the probability of hospitalization, costs, and seasonality, and results were more favorable in scenarios with higher risk of hospitalization, lower costs, and alternate seasonality. Thank you, and I'll turn things back over to the chair.
Thank you, Dr. Prosser. We now can take questions for either of these presentations for Dr. Link-Ellis or for Dr. Prosser. Dr. Cotton.
Dr. Prosser, thank you for the excellent presentation. Can you comment about immunocompromised? And I don't think it specifies whether or not they were included in the modeling.
Great, thanks very much for that question. No, as in the previous version of this analysis, we have not explicitly considered immunocompromised individuals in this analysis. And so these should be considered to apply to an immunocompetent population.
Thank you.
Although I will add to that, I mean, to the extent that that there could be some inferences drawn from the higher hospitalization rates or other higher risk scenarios that might correspond to an immunocompromised population, but we did not explicitly define those in that way.
Thank you.
Thank you. Dr. Lair?
Thank you for this presentation. Could you go to slide 21, please? I just want to make sure I'm understanding this. So if I had someone who, for example, had severe obesity that had a 4.4 times higher rate of hospitalization, then the two-dose regimen would only have a QALY or an ICER of $34,000. Is that a fair?
That's correct. Yep, that's correct. Yep.
Thank you.
Any other questions? Dr. Daly.
Yeah, I just want to thank both speakers, such clear presentations. I have a question for Dr. Link-Ellis. Actually, a comment first, so prepare to be embarrassed, Dr. Link-Ellis. You present that brilliantly. Every time I see a talk that's coming, I know that it's going to be, I'm going to learn something. It's going to be clear. You set it up so that what comes, it's just brilliant. And I don't know that we sort of thank you enough over the last years, but thank you so much for that. So this is a question that I've asked you before about relative and absolute VE, and I don't know whether it's worth bringing up slide 6, but there's a perception, there may be a perception in the public, the vaccines are getting less effective. And when we compare the news of November 9th of 2020, when we heard that these vaccines were 94 to 95% effective, then we look at this 50% effectiveness and say, that's just not that compelling. But I wonder, you've taught me that those are completely different things, because now it's a group, the vaccinated have this history, they've had multiple vaccines in the past plus infection, and then the unvaccinated or the comparison group also comes into the comparison with some immunity. And so it's a really different thing. So can you help me interpret, am I interpreting it correctly? And then can you help me think about how we convey that a 50% vaccine effectiveness in this context still prevents a bunch of bad stuff, hospitalizations and deaths.
Yeah, absolutely. First, thank you for your kind words, and yes, I am embarrassed. I think context here is so important. So if you think back to where we were in the early parts of the pandemic, when most of the population had yet to be infected, had received 0 doses collectively of vaccine, the vaccine had the opportunity to protect almost absolutely. So we saw that reflected in the clinical trials with vaccine effectiveness in the 90s. There was nowhere for us to go but up as far as our sort of collective immunity went from COVID-19. We're in a completely different place now in the pandemic. As you can see from this slide, most people in the population have been infected. If you add in people that have been vaccinated and not infected, you're really close to 100%. I think it's about 98% that have some kind of prior immunity, whether that be from infection, vaccination, or both. That prior protection provides protection against future infection as well as against future severe disease. But it doesn't protect absolutely. And so what the vaccines are doing now is providing an incremental benefit or an extra benefit beyond whatever benefit someone has remaining from their past infection or past vaccination. And we know that that protection from past vaccination and past infection wanes. So over time, whether you were infected or vaccinated multiple times, your protection will decrease. And the vaccines can then provide really important extra protection. They can boost whatever protection you have existing. That's important for all people in the United States, but especially important for those that are the highest risk. So thinking about pregnant patients, people with high-risk conditions, and those 65 and up. Thank you.
Thank you. Any addition?
Can I just have a follow-up question? So, Dr. Linkels, I was trying to think of another way to phrase this. And I just want to see if you agree with this interpretation, but if people entered this winter with a high degree of protection, then we wouldn't see much vaccine effectiveness in the real world because they already had protection. So this is sort of even in the setting of a lower disease burden, there are still preventable hospitalizations through vaccination across all ages, but particularly in the over 65.
Yeah, absolutely. I mean, if you think about what we study when we look at vaccine effectiveness, especially in a hospital setting, we need people to be hospitalized that both have COVID and don't have COVID. And if you consider that most people in the population have had COVID before, that means most people that are in the hospital with COVID-19, it's not their first infection. So we do know that even in the context of prior infection and prior vaccination, people are getting infected and being hospitalized and having critical illness and dying. And so the vaccine gives them that extra protection. And again, most important, of course, in those that have high-risk conditions.
Any additional questions, either from the ACIP members or the ex officios? Dr. Long.
So between you and Dr. Daly, you've educated us to the point that we have more questions. So the 50%, if you're sitting in the population, 50% lower chance of being hospitalized, as you've taught us to think about it, that was what was used in the cost effectiveness model, is that correct?
So the estimates from the cost effectiveness model came from Ivy and Vision, slightly older data, but yes, essentially it was the same.
So those relatively cost effectiveness of the booster is reasonable. And then the other thing I guess we would consider is we assume, or just because of all takers and most of the recent hospitalizations were in the winter time, and the last likelihood of being exposed, if you were that unboosted population, was some time ago, it assumes that there has been some waning of your prior immunization, whether it had been natural disease or vaccine.
Yes, and Dr. Prosser can comment on this in more depth, but her seasonality adjusted vaccine impact took into account waning of vaccine effectiveness.
Yeah, just to add to that, as Dr. Link-Ellis explained, that we use slightly older estimates from the bivalent booster dose to construct the scenarios of waning for estimating vaccine impact. But the results of the vaccine effectiveness presented here today correspond closely enough that even if we integrated these values directly into our analysis, that they would fall within the lower and upper bounds of what we've included in our cost effectiveness analysis.
Are there any other questions? So not seeing any, I think we can move on to Dr. Wallace.
Good morning. Next slide. Today, I will be presenting the evidence to recommendations framework for the policy question, should persons ages 65 years and older be recommended for an additional dose of the 23-24 formula COVID-19 vaccine? The additional dose should be at least 4 months after receipt of the previous updated COVID-19 vaccine dose. And as a reminder, the currently authorized and approved 23-24 formula COVID-19 vaccines include Moderna, Novavax, and Pfizer-BioNTech, and this policy question would apply to all three. Next slide. The reason we're asking this policy question is because there is a precedent for older adults to be recommended for an additional dose at least 4 months after the fall dose recommendation. Following the initial booster dose recommendations in the fall of 2021, an additional dose was recommended for those 50 years and older in May of 2022. Then, following the bivalent dose recommendations in the fall of 2022, an optional additional dose was recommended for those 65 years and older in April 2023. Now, as you all know, ACIP recommended the 23-24 formula COVID-19 vaccine in September. And today we're discussing if an additional dose should be recommended in older adults this year. Next slide. There are already recommendations for additional doses of 23-24 formula COVID-19 vaccine in people who are moderately or severely immunocompromised. They have the option to receive 1 additional dose of updated COVID-19 vaccine at least 2 months following the last recommended updated COVID-19 vaccine dose. And further additional doses may be administered informed by the clinical judgment of a healthcare provider and personal preference and circumstances. Any further additional doses should be administered at least 2 months after the last updated COVID-19 vaccine dose. Next slide. We'll begin with the public health problem domain. Next. This slide shows the weekly number of COVID-19 hospitalizations in the United States since January 2023. Hospitalizations appear to have peaked during the weeks ending December 30th and January 6th at about 35,000 hospitalizations a week. For the most recent week of data ending February 17th, there were nearly 20,000 hospitalizations. Throughout the last year, weekly hospitalizations never got below 6,000 new hospital admissions a week. Next slide. On this slide, we are still looking at COVID-19 hospitalizations, but now we are looking at hospitalization rates by age group over the past year from COVIDNet. The blue line represents hospitalization rates among those 65 years and older, with other colors depicting hospitalization rates in the younger age groups. As you can see, hospitalization rates are substantially higher in those 65 years and older compared with the other age groups. Over the last year, hospitalization rates among those 65 years and older have tended to be around 5 times higher than those ages 50 to 64 years. Next. Here we are again looking at the hospitalization rates over the last year, but now looking only in those 65 years and older, with those 65 to 74 depicted in blue, those 75 to 84 depicted in green, and those 85 and older depicted in black. Not surprisingly, we see that there is differential disease burden within the over 65 age group, with hospitalization rates increasing with increasing age. Next slide. On this slide, we are looking at the weekly number of provisional COVID-19 deaths reported to CDC. Deaths appear to have peaked the week ending January 13th at around 2,500 deaths per week and are now decreasing. At the lowest point last summer, there were still about 500 COVID-19 deaths a week. Next slide. And when we look at the monthly rate of provisional COVID-19 deaths by age, in the figure on the slide, we see that those 75 years and older, depicted by the burgundy color line, had a substantially higher death rate over the past year than the younger age groups. The hospitalization rates tend to be around 6 times higher in those 75 years and older than those 65 to 74 years, who in turn have rates around 3 to 4 times higher than those 50 to 64 years. Next slide. This slide shows the weighted U.S. SARS-CoV-2 seroprevalence by vaccine and infection history and age based on blood donations from July 1st to September 30th, 2023. Vaccine-only seroprevalence is depicted in yellow, infection-only seroprevalence is depicted in blue, and hybrid immunity is depicted in green, and neither past infection nor vaccination is depicted in dark blue. The rows represent different age groups. Across age groups, seroprevalence is at 98% or greater. However, those ages 65 and older have a higher proportion with vaccination-only seroprevalence at 26% compared to those in the younger age groups. Next slide. And when we think about this older adult population, we also need to consider the role of immunosenescence. At birth, we have large thymuses, a large pool of naive T cells that do not recognize specific pathogens, and no memory T cells that do recognize specific pathogens. Beginning in early childhood, continuing throughout our life, our thymuses decrease in size and our pool of naive T cells decrease. At the same time, as we are exposed to pathogens, we develop memory T cells that can be maintained for a lifetime and are poised to respond quickly if we see that pathogen again. Again, these changes start at birth and accumulate over time, so by the time we reach older adulthood, we have fewer naive T cells to respond to new pathogens, but a robust pool of memory T cells from nearly every pathogen we've encountered throughout our lives. Again, this process is called immunosenescence. Next slide. While the process of immunosenescence I just described is related to T cells are central in helping other arms of the immune system. They are necessary to generate pathogen-specific cytotoxic T cells, which kill infected cells, and they help stimulate B cells to generate antibodies. Therefore, the paucity of naive T cells can affect the ability for a person to clear virus-infected cells and to generate good quality and high-titer antibodies against a new pathogen. If a person does not have sufficient pools of naive T cells, as is often seen with older adults, they may not generate robust, long-lasting neutralizing antibody responses or good memory cytotoxic T cells. Next slide. I also want to talk about the seasonality of SARS-CoV-2. This slide shows the weekly percent of tests positive for COVID-19, influenza, and RSV in the United States since October 2022. What we see is that influenza, depicted in blue, and RSV, depicted in purple, have clear increases in percent positive during the typical respiratory virus months, with very low percent of tests positive from about March to September. The pattern for COVID, which is depicted in orange, is not as striking. While there are obvious increases during the winter months, there is ongoing detection throughout the year. Next slide. And this is also demonstrated in the rates for severe outcomes. The figure in this slide shows the weekly hospitalization rates per 100,000 population since October 2022, with influenza rates represented by the blue line and COVID rates represented by the orange line. We see that both influenza and COVID have increased hospitalization rates during the winter months. In the spring, influenza hospitalization rates declined sharply and remain low until the fall, while COVID-19 hospitalization rates decrease at a slower rate and never reach rates as low as those seen for influenza. Next slide. Now we'll move to the domain equity question. Does the problem impact all populations equally? Next slide. This slide shows the age-adjusted cumulative COVID-19 hospitalizations per 100,000 by race and ethnicity in the United States from October 2022 to September 2023. As you can see, there are still disparities in COVID-19 hospitalization rates, particularly notable for American Indian and Alaska Native and Black people. Next slide. The figure on this slide shows the percent of people with multiple chronic conditions by age and race ethnicity. As we can see, there are differences by race and ethnicity in the percent that have multiple comorbidities at younger ages. This might be contributing to some of the inequity we are seeing in the burden of COVID-19 by race and ethnicity. Therefore, this is important context to keep in mind as we consider age-based recommendations. Next slide. In summary, COVID-19 hospitalizations peaked in late December, early January. However, there are still approximately 20,000 new hospital admissions and 2,000 deaths due to COVID-19 each week. Persons ages 65 years and older have the highest COVID-19 hospitalization rates, and hospitalization rates within this age group increase with increasing age. Persons ages 75 years and older have the highest COVID-19 mortality rates. Immunosenescence and higher prevalence of vaccine-only immunity in older adults compared to younger adults suggest that more frequent doses may be needed to maintain protection in this population. While there are increases in COVID-19 during respiratory virus season, COVID-19 hospitalizations and deaths continue throughout the year due to ongoing circulation of SARS-CoV-2. Inequities in COVID-19 hospitalizations by race and ethnicity continue and should be considered in the context of an age-based recommendation. Next slide. When asked, is COVID-19 disease among persons ages 65 years and older of public health importance, the work group opinion was yes. Next. Now we'll move to the benefits and harms domain. Next. Dr. Linkel has previously presented on the 23-24 formula COVID-19 vaccine effectiveness, and in her presentation, we saw that updated COVID-19 vaccination provided increased protection against symptomatic SARS-CoV-2 infection and COVID-19 associated ED/UC visits and hospitalizations compared to no updated vaccine dose. Receipt of updated COVID-19 vaccine provides protection against JN1 and other circulating variants. And these are early vaccine effectiveness estimates that show no substantial waning. However, waning is expected. Next slide. These are data from Vision, which Dr. Link-Gellis presented in September at the September ACIP meeting, looking at the absolute VE of original monovalent and bivalent doses against hospitalization among immunocompetent adults by age group. As you can see in the red boxes on the right, vaccine effectiveness decreased with time since the last dose, and this is what we've come to expect. Next slide. On this slide, which was also presented back in September, we are still looking at Vision data, and here we see the absolute VE of original monovalent and bivalent doses against hospitalization and critical illness among immunocompetent adults. At the top of the slide, we see the VE against hospitalization, which clearly demonstrates the waning that we discussed in the previous slide. At the bottom, we see VE against critical illness. Although confidence intervals are wider for this outcome, the data suggests that VE against critical illness may be more durable than that seen against less severe outcomes. Next slide. As for effectiveness of an additional dose of COVID-19 vaccine, there are no clinical trial immunogenicity data of an additional dose of 23-24 COVID-19 vaccine. However, the initial dose of 23-24 COVID-19 vaccine elicits robust neutralizing antibodies and provides protection against JN1 and other circulating variants. The effectiveness of an additional dose in older adults has been demonstrated by past additional doses. Among adults aged 50 years and older eligible to receive a second original monovalent mRNA COVID-19 vaccine booster dose, VE for COVID-19 associated ED/UC encounters during the BA2 period was 32% at 120 days or more after the third dose, but increased to 66% 7 days or more after the fourth dose. VE against COVID-19 associated hospitalization was 55% 120 days or more after the third dose, but increased to 80% 7 days or more after the fourth dose. Additionally, in a large cohort of nursing home residents, receipt of a second original monovalent mRNA COVID-19 booster dose during the circulation of SARS-CoV-2 Omicron subvariants was 74% effective at 60 days against severe COVID-19 related outcomes, including hospitalization or death, and 90% against death alone compared with receipt of a single booster dose. Next slide. Next slide. Sorry, I didn't realize this was keep going, sorry, until the slide's all up. Thanks. Next. Okay, apologies about that. A recent microsimulation modeling study compared the frequency of COVID-19 vaccination by risk group. In this study, they assigned risk groups by age and immune status and simulated vaccine-induced or hybrid protection. The model was calibrated to the epidemiology seen in September of 2022, and the simulation of different vaccine strategies was run over a 2-year time horizon. Next slide. Next. Thank you. The study found that annual and semi-annual, or every 6-month COVID-19 vaccine doses has largest benefit in people ages 65 years and older and in people who are immunocompromised. Looking at the bottom red box, we see that this model estimates semi-annual dosing would result in an annual risk reduction of 142 severe COVID-19 cases per 100,000 in those 65 to 74 years, and 368 severe COVID-19 cases per 100,000 in those 75 years and older. This corresponds to a number needed to treat to avert severe COVID-19 of 353 in those 65 to 74 years, and 136 in those 75 years and older. Next slide. COVID-19 vaccines have a favorable safety profile as demonstrated by robust safety surveillance over 3 years of COVID-19 vaccine use. Anaphylactic reactions have been rarely reported following receipt of COVID-19 vaccines. There is a rare risk of myocarditis and pericarditis. However, this is predominantly in males ages 12 to 39 years. No new safety concerns have been identified for the 23-24 formula COVID-19 vaccine. Reactogenicity symptoms have been reported following COVID-19 vaccines. Local reactions, including pain at the injection site and less commonly, redness and swelling at the injection site. Systemic reactions include fever, fatigue, headache, chills, myalgia, arthralgia, and diarrhea. Overall, these symptoms are less frequent and severe among older adults compared with adolescents and younger adults. Next slide. A statistical signal for ischemic stroke after Pfizer-BioNTech bivalent mRNA COVID-19 vaccine was detected in CDC's vaccine safety data link in persons aged 65 years and older during the fall of 2022. Information was presented at prior ACIP meetings, and efforts have been underway to evaluate the signal. The available data do not provide clear and consistent evidence of a safety problem for ischemic stroke with bivalent mRNA COVID-19 vaccines when given alone or given simultaneously with influenza vaccines. Variable and inconsistent results were obtained in some analyses of the risk of ischemic stroke following bivalent mRNA COVID-19 vaccination, simultaneous bivalent mRNA COVID-19 and influenza vaccination alone. Most study results have not shown an association between vaccination and ischemic stroke, and no clear pattern demonstrating increased risk has emerged. Next slide. Any real or theoretical risk needs to be placed in the context of the known benefits of COVID-19 vaccination in preventing COVID-19 disease and the potentially serious complications, including stroke. A recently published MMWR demonstrated that among adults aged 65 years and older, a recent bivalent mRNA COVID-19 vaccine dose helped provide protection against COVID-19 related thromboembolic events compared with more distant receipt of original monovalent doses alone. Next slide. For the domain equity question, we asked, are the desirable and undesirable anticipated effects demonstrated across all populations equally? Next slide. There is no evidence to suggest that COVID-19 vaccine effectiveness varies substantially by race and ethnicity. Differences in vaccine hesitancy and uptake, crowding, access to care, and prior infection could impact vaccine effectiveness, and these factors may also differ by race and ethnicity. There is no evidence to suggest that COVID-19 vaccine safety profiles vary by race and ethnicity. However, risk has been shown to differ by age and sex. The risk for myocarditis is highest in adolescent and young adult males. Benefits and harms for the U.S. population are always best assessed when clinical trial and study participants are optimally representative of the U.S. population. Next slide. In summary, 23-24 formula COVID-19 vaccination provided increased protection against symptomatic SARS-CoV-2 infection and COVID-19 associated ED/UC visits and hospitalizations compared to no updated vaccine dose. COVID-19 vaccine effectiveness from previous vaccine formulations has waned over time, but appears more durable against critical illness. An additional dose of 23-24 formula may restore vaccine effectiveness, which is expected to wane, providing additional protection until the next updated vaccine is available. COVID-19 vaccines have a favorable safety profile. Local and systemic symptoms have been reported following receipt of COVID-19 vaccines. However, symptoms are less frequent and severe among older adults compared with adolescents and younger adults. The available data do not provide clear and consistent evidence of a safety issue for ischemic stroke with bivalent mRNA COVID-19 vaccines, either when given alone or when given simultaneously with influenza vaccines. Next slide. When asked how substantial are the desirable anticipated effects, the workgroup judgment was moderate. Next. When asked how substantial are the undesirable anticipated effects, the work group majority opinion was small, with a minority opinion of minimal. Next. Finally, when asked do the desirable effects outweigh the undesirable effects, the work group felt it favored the intervention. Next. Now we will move to the values domain. Next. This slide shows key attitudes and experiences among adults from the National Immunization Survey, with adults ages 65 years and older designated by the green bars. In the group of bars on the left side of the figure, you see that 41% of those 65 and older report that they are concerned about COVID-19. Then moving to the next group of bars, 65% of older adults have confidence in COVID-19 vaccine safety. And on the far right, we see that 78% have confidence that COVID-19 vaccine is somewhat or very important for protection. When looking across age groups, we see that adults aged 65 years and older were more concerned about COVID-19 and more confident in vaccine safety and importance than the younger age groups. Next slide. This figure shows the percent of adults that say they are taking precautions because of COVID-19, with half of adults reporting that they are taking at least one of the precautions listed. Most commonly, people reported planning to avoid large gatherings, mask in crowded places, and avoid travel. Next slide. When considering these precautions by age, we saw that similar shares of younger and older adults reported plans to take at least one precaution during the fall and winter. However, 4 in 10 adults ages 65 years and older say that they plan to avoid large gatherings, compared to a third of those under the age of 65. While younger adults were less likely to say they will avoid large gatherings, 21% of those 65 years and younger, or less than 65 years, say that they will take a test for COVID-19 before spending time with friends or family, compared to 10% of those 65 years and older. Next slide. The domain equity question is there important variability in how patients or populations value the outcome? Next slide. This figure shows the same key attitudes shown previously, but now stratified by race and ethnicity. Looking at the left cluster of bars, we note that Black adults report the most concern about COVID-19 disease, but all groups are around the 30 to 40% range. When we look at the two groups of columns on the right, which represent COVID-19 vaccine confidence, we see that there is substantial variability by race and ethnicity, with Asian adults reporting the highest confidence and American Indian and Alaska Native adults reporting the lowest. Next slide. On this slide, we are again looking at the percent who say they are taking COVID-19 precautions, but this time it is broken down by race and ethnicity. Here we see that a notably higher percent of Black and Hispanic adults report planning to take COVID-19 precautions compared to white adults. Next slide. In summary, adults ages 65 years and older were more concerned about COVID-19 disease and had higher confidence in vaccine safety and vaccine importance than those 65 years and less than 65 years. Black adults were more concerned about COVID-19 disease than people of other racial and ethnic groups. Confidence in COVID-19 vaccine safety and importance varied by race and ethnicity. Half of adults report that they plan to take precautions because of COVID-19 during the fall and winter months, with 41% of adults ages 65 years and older planning to avoid large gatherings. Larger proportions of Black and Hispanic adults report that they plan to take precautions against COVID-19 than white adults. Next slide. When asked, do older adults feel that the desirable effects are large relative to the undesirable effects, the work group opinion was large. Next slide. When asked, is there important uncertainty about or variability in how older adults value the main outcomes, the work group opinion was probably important uncertainty or variability, with a minority opinion of probably no important uncertainty or variability. Next slide. Now we move to acceptability. Next. This figure, which you also saw in Dr. Chatham's slides, shows the percent vaccinated with the 23-24 COVID-19 vaccine based on the National Immunization Survey. We see that coverage for those 65 to 74 years and those 75 years and older, which are represented by the purple and blue lines, is greater than 40%, which is notably higher than for the other age groups. Next slide. When adults aged 65 years and older were asked about their top COVID-19 concerns and issues, those that had already received or definitely will get the vaccine reported vaccine effectiveness as their largest concern. However, 84% reported no concerns or issues at all. Unknown serious side effects was the most commonly reported concern for those that said they probably will get the vaccine or are unsure, and those that probably or definitely will not get the vaccine. For those that said that they probably will get the vaccine or are unsure, no provider recommendation was the second most commonly listed concern at 12.6%. Next slide. We know that healthcare provider recommendation is a key driver of vaccine uptake. In December, only 19% of adults reported receiving a healthcare provider recommendation, and this report of receiving a recommendation was highest in those that had already received vaccination or definitely planned to get vaccinated. Next slide. And when we look at provider recommendation by age, we see that reports of a healthcare provider recommendation for COVID-19 vaccine was highest among adults aged 65 years and older compared to the younger age groups. Next slide. Finally, when those that had already received the 23-24 COVID-19 vaccine were asked if they would receive an additional dose of the 23-24 COVID-19 vaccine if it was recommended for them, there was relatively high intent across the board. But this was particularly true for those 65 years and older, in which 68% reported that they would definitely would get another dose if it was recommended. Next slide. The domain equity question was, is the intervention equally acceptable across all populations? Next. Among adults aged 18 years and older responding to the NIS ACM during November 26th to December 30th, vaccination coverage differed by race and ethnicity. Coverage was highest among white, non-Hispanic adults and lowest among American Indian and Alaska Native and Native Hawaiian and other Pacific Islander adults. Vaccination coverage was higher in urban and suburban areas compared to rural areas. Adults with health insurance had significantly higher vaccination coverage than adults without insurance. And vaccination coverage increased with increasing household income. Next slide. And when we asked this question about intent to receive an additional dose if recommended among those that had already received a 23-24 vaccine dose, despite high intent overall, if you look at the red box, we see that Black and Hispanic adults were more likely to report that they probably or definitely will not receive an additional dose, which is shown in purple. Next slide. In summary, as of February 2024, vaccination coverage with the 23-24 COVID-19 vaccine was highest among older adults ages 65 to 74 years and 75 years and older compared to younger age groups. Disparities in COVID-19 vaccine coverage are observed across many demographic factors, including race, ethnicity, insurance status, and rurality. Adults who were vaccinated or definitely planned to get vaccinated were more likely to report that a healthcare provider recommended that they get a COVID-19 vaccine. Adults 65 years and older were more likely to report a healthcare provider recommendation than younger adults. Among adults 65 years of age and older who had already received a 23-24 formula COVID-19 vaccine dose, 68.4% reported that they definitely will get an additional dose of 23-24 formula COVID-19 vaccine if it is recommended for them. Next slide. When asked, would recommending an additional dose of 23-24 formula COVID-19 vaccine for older adults be acceptable to key stakeholders, the workgroup majority opinion was probably yes, with a minority opinion of yes. Next. Now we will move to feasibility. Next. COVID-19 vaccines are now available on the commercial market. They are covered by private and public insurance and available through the Bridge Access Program and Vaccines for Children for those that are uninsured or underinsured. An ACIP recommendation would be needed for insurance coverage of an additional dose of 23-24 formula COVID-19 vaccine. Insurance coverage is generally required under either a should or a may recommendation. Next slide. The additional dose recommendation would be for the same formula of COVID-19 vaccine that is currently available, and existing COVID-19 vaccine administration infrastructure and product can be used. An age-based recommendation would not be overly burdensome to implement. However, an additional dose recommendation in those 65 years and older would add complexity to COVID-19 vaccine recommendations, which have been getting simpler. Frequent changes to vaccine recommendations can lead to vaccine fatigue. Systems are already planning for next season, and adding more recommendations for this year could add additional burden to an already fatigued system. The minimum interval of 4 months used for additional dose recommendations may confuse providers accustomed to the 2-month interval from the fall dose. Providers would need to consider anticipated availability of updated vaccine next fall when considering providing vaccine doses during the summer months. Next slide. For equity, we asked, is the intervention equally feasible to implement across all populations? Next slide. We have heard past reports of sites being unaware of additional dose recommendations or requiring documentation to prove eligibility for an additional vaccine dose. Wide communication of any change in recommendations and that self-attestation is appropriate will be important to decrease barriers. The Bridge Access Program was designed to remove patient barriers to COVID-19 vaccines. However, disparities in vaccine uptake by insured status continue. To the extent that existing disparities in vaccine uptake by characteristics such as race, ethnicity, urbanicity, and income are driven by differences in vaccine access, additional dose recommendations may further increase those disparities, and access issues may be increased during a time when there are fewer off-site vaccination clinics, which are more common during fall vaccine rollouts. In the absence of an ACIP recommendation, additional doses might be an out-of-pocket cost. Therefore, those able to pay for an additional dose may have access while others do not. Next slide. In summary, COVID-19 vaccines are currently on the commercial market, and an ACIP recommendation would be needed for insurance coverage of an additional dose. An additional dose recommendation would leverage existing infrastructure and vaccine product. However, it would add complexity to the current recommendations, which could enhance vaccine and system fatigue. Access-related barriers to COVID-19 vaccines and disparities in vaccine uptake remain, and additional dose recommendations may further heighten those inequities. But lack of recommendation limits access to those able to pay for vaccine out of pocket. Next slide. When asked, is an additional dose of the 23-24 formula vaccine feasible to implement among older adults, the workgroup opinion was probably yes. Next. And now for resource use. Next. You all saw the full economic analysis presented by Dr. Prosser, but as a brief reminder, an additional dose in those 65 years and older had an incremental cost-effectiveness ratio of about $250,000 per quality-adjusted life year. However, the ICERs became more favorable in scenarios that approximated the higher risk which may be seen with underlying medical conditions or advanced age. Next slide. For equity, we considered, is the intervention a reasonable and efficient allocation of resources across all populations? Next slide. An additional dose of COVID-19 vaccine is most cost-effective in older adults in which disease burden is highest compared to younger adults. An additional dose of COVID-19 vaccine is likely more cost-effective in populations with a higher prevalence of risk factors, such as underlying conditions, which increase their probability of hospitalization due to COVID-19. Next slide. In summary, the cost-effectiveness of an additional dose in older adults is highly sensitive to COVID-19 associated hospitalization rates, and anticipated rates in the coming months are uncertain. COVID-19 associated hospitalization rates in older adults that are higher than those seen last year would increase the cost-effectiveness. However, lower COVID-19 hospitalization rates would decrease the cost-effectiveness. Estimates that approximate cost effectiveness for those with high-risk conditions, such as underlying conditions or advanced age, are more favorable. Next slide. When asked, is an additional dose of the 23-24 formula COVID-19 vaccine in older adults a reasonable and efficient allocation of resources, the workgroup response was probably yes. Next slide. Now we'll finish with the summary and workgroup interpretations. Next slide. The greatest benefit of a vaccine dose would be in those who have not yet received a 23-24 formula dose, particularly older adults and those with underlying medical conditions. The data presented today emphasize the importance of any dose of updated COVID-19 vaccine in older adults. Risk of severe illness due to COVID-19 continues throughout the year and is highest in those 65 years and older. Within the 65-year and older age group, risk increases with increasing age. Receipt of the 23-24 formula COVID-19 vaccine provides protection against JN1 and other circulating variants. However, vaccine effectiveness is expected to wane. In the past, we have seen greater durability in the protection against critical illness. Next slide. A May recommendation would provide flexibility for older adults to obtain an additional dose if they or their healthcare provider feel they would benefit. The most benefit would likely be in those with underlying medical conditions, advanced age, or circumstances that may increase risk, such as being a nursing home resident. An additional dose in adults 65 years and older may restore protection that has waned. However, this will be a smaller, incremental benefit on top of the protection that is still being provided by the initial 23-24 formula COVID-19 vaccine dose. The cost effectiveness of an additional dose depends on COVID-19 hospitalization rates in the coming months and the patient risk factors for severe illness due to COVID-19. Finally, as COVID-19 epidemiology changes with time, additional dose recommendations may not be needed in the future. Next slide. When considering an additional dose recommendation, the work group felt that a May recommendation would provide flexibility for those 65 years and older to get an additional dose if they or their healthcare provider feel they would benefit. It could restore vaccine effectiveness that may have waned since the initial 23-24 COVID-19 vaccine dose, and it acknowledges that risk of severe illness due to COVID-19 continues throughout the year for older adults, despite upticks during the winter months. The work group also acknowledged that this would have a smaller, incremental benefit compared to that from the initial 23-24 COVID-19 vaccine dose in the fall. It also may decrease vaccine confidence in the benefits of a single dose of 23-24 COVID-19 vaccine. And additional recommendations may increase vaccine fatigue, potentially reducing uptake of vaccine next fall. Next slide. And here is a summary of the work group judgments that we just went through. Next slide. For the overall balance of consequences, the work group was split between judgments that the balance between desirable and undesirable consequences is closely balanced or uncertain, and desirable consequences probably outweigh undesirable consequences in most settings. Next slide. For type of recommendation, the majority polled to recommend the intervention for individuals based on shared clinical decision-making, which for COVID-19 vaccines has typically been referred to as a May recommendation. Next slide. The proposed ACIP vote language is, ACIP recommends that persons greater than or equal to 65 years of age may receive an additional dose of the 2023-2024 formula COVID-19 vaccine. Next slide. And as for an idea of our proposed clinical considerations language, it would likely read, people ages 65 years and older may receive one additional dose of any updated COVID-19 vaccine informed by the clinical judgment of a healthcare provider and personal preference and circumstances. Considerations for the additional dose may include a person's risk for severe COVID-19 due to age and the presence of underlying medical conditions. The additional dose is administered at least 4 months following the previous dose of updated 23-24 formula COVID-19 vaccine. Next slide. And before I close, I want to acknowledge this incredible group of people that contributed to the presentation. Next slide. Thank you.
Thank you, Dr. Wallace, for that very impressive overview. Could you put the proposed vote language back up, please? So we now can take some questions for Dr. Wallace, discussion around this proposal from the work group. Dr. Lair.
Thank you for an excellent presentation. I have several questions. Did the work group consider just recommending this for people over 75? Because there seems to be a fairly dramatic change between 65 and 75.
Yes, the work group did have considerations of other age groups, including the 75-year and older age group. One of the key drivers that led to dropping it down to 65 was the equity concerns that a 75-year and older age group would likely cause inequities for those in minority groups that are still experiencing severe illness in the 65 to 74 age group.
Dr. Long.
It'll be a question about timing of the vaccine that may be given. And it is, I don't remember, I know you showed us some data on waning at 100 and half a year. Did you show us at a year? And was the information that probably Dr. Taylor showed us of the effectiveness of the monovalent booster, an average of only 3-4 months after vaccination. So it's a question of waning and how soon or how long can you, although the protection against critical disease, I appreciate, lasts a little longer. I wonder if there's an end point to that. And then if there's a guru anywhere who knows anything about COVID in a reverse climate from ours, do we know what's happening, as we do know with seasonality and types of influenza vaccine from tropical climates? Do we have any information about COVID, and will we have this spring odd bump, or are we likely to revert to a winter virus like the other winter viruses, when it would be much better to give people their next dose not 4 months after the last dose, but in the fall? Lots of questions, probably unanswerable.
Thank you. If we could go to slide 24. So, these are the data that we presented looking both at bivalent and monovalent, and I'll defer to Dr. Link-Ellis if she has anything that we want to add, but it seems like by, 180 days, the bivalent protection against hospitalization had returned to about what we were seeing for a monovalent dose. And so if we're going off of that, I think that's, what we are anticipating the updated dose to respond like. Anything?
No, nothing to add.
And then the question about seasonality, I think, is a really good one, and I think it's one that we are all asking, because I think it would certainly inform the recommendations. I think this last year we saw much lower rates in the spring and summer than we did the previous 2 years. But I think we all feel that things with COVID are still unpredictable, particularly as new variants arise. So I hope that we are moving in the direction of getting more flu-like, where there's a really clear season, but I don't think that we are there yet. If others know more than me, I believe the Southern Hemisphere is seeing similar to what we are seeing, where there's year-round circulation, but it is higher in the typical respiratory virus months for them.
It seems like it'll be difficult to inform providers on what they ought to do with this recommendation as far as timing. We got the booster in October, so they're thinking respiratory season. And it'll be difficult for you to, since I don't know if we polled the practitioners here, maybe Dr. Lair, what would you do with this recommendation? Would you give certain people a booster right now, or would you sort of wait to see what's happening with the epidemiology and try to give it closer to when they might be at more risk?
Thank you. I'm wrestling with the should versus may, because I'm thinking that there's actually a fair amount of benefit here, and I tend to be more flexible, and the should is sort of appealing to me at this point, but I can see lots of reasons why the may makes sense, including cost effectiveness, seasonality. But if you're asking my personal opinion, I would probably give this again in February or March for those people who are particularly high risk, those over 75, those immunocompromised, those who have high risk conditions. So I think it's a good idea in general, and I'm personally just wrestling with the should versus may. Thank you.
Dr. Cotton.
Thank you, Dr. Lair. I have similar thoughts. If we see that really the minority of the U.S. population has received the updated vaccine, from my perspective as an active clinician in the field, many people did not even know that when I speak with them, did not even know that they should have had an updated vaccine since September. So if we say May, for me, that's too soft. The American public is really not aware of the fact that they actually should be getting these vaccines. They should have already had the 2023-2024 updated vaccine, but the majority have not. And so I think clarity on this May is too soft for me, especially for the most vulnerable populations. I do agree that it is not entirely clear that a very healthy, robust person just over the age of 60, they may not benefit as much, and the QALYs may not be as supportive for vaccinating that population. But there are many people for whom lives could be saved. And from a public health perspective, I am concerned if we don't make a clear-cut recommendation. Thank you.
Are there other questions from the committee? Dr. Long.
So am I understanding that you're trying to separate Dr. Lair and Dr. Cotton? Those who never received an updated vaccine, that should be a should, and whether they should receive a second dose could be a may? Dr. Cotton, you're shaking your head, but I don't think people can hear it.
Thank you, Dr. Long. I'm glad no one can hear me shaking my head. That would be concerning. I actually would advocate for clarity for both. Should get the updated vaccine, which is what we said in September, and then should get an additional dose for people in the highest risk group. And furthermore, I would also advocate for clarity. One of the issues, if we're thinking about at least 4 months after the prior dose, and then for immunocompromised, it's 2 months after the last dose. It's really confusing to clinicians. I get so many questions. So I would think about what we can do to provide clarity and simplicity. Thank you.
Are there other, Dr. Sines?
I would also like to voice my agreement with Dr. Cotton. I believe that harmonizing the should for both first dose and a second dose will make it easier for providers and counseling patients, as well as for uptake on patients maybe getting their first updated vaccine if they haven't received it already. Thank you.
Can we get the proposed vote language back up, please? Dr. Brooks.
So, the work group did have this discussion in terms of should versus may, and the con slide, though, slide 74 was relevant because that's beyond the science. We still have to get the population vaccinated. We're having more vaccine hesitancy. Information was provided for that. And there was concern about vaccine fatigue, the lack of confidence in the single dose. I mean, the people that are under 65, well, why don't I get two? And there's obviously data, but they're not going to get that data. So if you really need to, then next year I'm going to have to get two, so I don't really want to get any. I think that allowing the flexibility of of may versus should, in the end, may get more people vaccinated, both lower than 65 years of age, immunocompromised, versus those 65 and older.
Dr. Lair.
So I appreciate that perspective. I would say, however, that most people are coming in either wanting the vaccine or not. And when they come in, and I think we have a data in here that for the people who've already gotten their 2023, 2024 formula, they actually, 68% of them would be happy to get a booster if they know that it's recommended. So I think people are already coming in with their opinions, so I'm looking more about the providers. Can I make it easier for the providers to say, yes, we recommend this, and you should just simply recommend this for everybody who walks in the door who fits the criteria. I'm still not sure how I'm going to vote on this, but I don't think a May would get more people vaccinated. That's my opinion. Thank you.
Do we have a motion? Do we need additional discussion? Dr. Daly.
Well, I just appreciate the perspective. I really do, and just want to acknowledge that the work group did consider a number of these options. I don't know that I have a perfect answer, and because there was some disagreement, or at least difference of opinion on the part of the work group. I mean, in some ways, the May recommendation is a reflection of some difference of opinion on the part of the work group. You know, I think we all recognize that communication is key, and how strongly a provider endorses this in their practice is really important. And we also recognize that now there's a lot of different settings where vaccination is occurring, and this is also happening in pharmacies, for example, and that might not entail a long conversation. It might not be with a pharmacist who knows somebody's individual sort of health status. So in some ways, because there was a difference of opinion on the part of some work group members that is in some ways reflected in the May, that doesn't mean that that's necessarily the decision where we need to land, but I think it's an acknowledgement of that. So let me just mention a couple of those who had more reservations. There was a work group member who said, you know, I'm not sure it's needed, okay? And I think that's a reflection of how much burden is there gonna be in April, May, June, July, August. I think that's a question of that. And then the question of harms came up a little bit, and the harms, again, posed by this work group member were not in terms of specific adverse events following vaccination, but just this more theoretical concern about whether that sort of blunts your immune response next fall. And so it was really more of a theoretical concern there. So that was some of the difference of opinion on the part of the work group, and that's, I think, part of what's reflected in a May recommendation. However, we all recognize that communicating this is a challenge, and that it might be harder to communicate a May recommendation than a should recommendation, in which case you can just say, you know, you should get your vaccine today, and then perhaps it's not as long a conversation. So I'll stop there and see if anybody has anything else to add. Thank you.
So I move that we accept the language as presented here, specifically saying may receive an additional dose.
Okay, we have a motion for the work group language. Do we have a second?
It's Brooks, second.
Okay. Dr. Daskalakis, did you want to make a comment?
Sorry, excuse me. Jimmy, did you say to remove May? To leave it, to have the language as is?
To leave the language as is.
Yeah, thank you. Right.
Just, I was clarifying that the May is, leaving the May in place.
Question about Robert's rules.
Yes.
Are we trying to see if there is broad agreement for this motion before an amendment?
So if there is an amendment to strengthen if someone wants to make a motion to strengthen this recommendation, for example, to a should recommendation, that motion can be made and would be voted on now. If that motion doesn't pass, then the motion that Dr. Lair just made will be what we vote on this afternoon.
Can we set aside the motion that's been seconded now?
No, we can't set it aside, but we can amend it. So if someone would like to propose an amendment to this motion that makes it stronger, we can do that. Dr. Cotton?
I would like to make a motion to amend this to read should rather than may.
Okay, so there's a motion to amend. Is there a second for the motion?
I second the motion.
Okay, so we have a motion and a second to amend the motion to make this, ACIP recommends that persons 65 years of age and older should receive an additional dose of the 2023-2024 formula COVID-19 vaccine. Dr. Daskalakis?
As we sort of approach the vote, I just wanted to step in and just talk a little bit about the may versus should for a moment, which is, so the note, and I just wanted to sort of echo what Dr. Daly said, which is that, you know, the may sort of provides the sort of permissiveness for people who are already very connected to vaccine and interested in vaccination. So I think that the note from Dr. Cotton that we need to do better in terms of communicating the importance of the initial dose, I think is completely true. I just want to say that more absolute statements around vaccines sometimes will create a chilling effect for the folks who haven't been vaccinated. So just sort of putting it out there that in this scenario, it may be worth thinking about the population who we're talking about, which are folks who have already been vaccinated, who are like suggestible for vaccine, and who will likely take this recommendation sort of on the value of an additional dose of something that may be right for me. So just want to put that out there as you all have the discussion and move to a vote.
Dr. Daskalakis, can we have information on that topic so that that could inform our decision making?
Could you, like, one more time?
Could you provide additional information backing that statement up? Because as a clinician who provides a tremendous number of vaccines to adults, I have not necessarily found that to be true in my practice. And for me, when the CDC says may, they think, oh, may, like may doesn't really mean anything. That doesn't mean me. It doesn't mean I need to do it. And should is quite clear. So I am concerned, although I definitely believe that what you say is true, I would like additional data to back up what you have said.
Dr. Long.
And I wonder if are you intending to call these questions now? I would like to have a little more time to think, because this is, you know, it's a very difficult decision. I also wonder if, does the word should have to be there? Couldn't you just delete may, and then we wouldn't get hung up on should? The implication would be should, but the ACIP recommends that 65-year-olds receive. That's good English language.
So I think that is acceptable language for an ACIP recommendation. It is not how many of our COVID vaccines have been worded, but we certainly word many other recommendations that way, and I think that would be acceptable. But that would be an amendment, because we already have an amendment. Dr. Cotton.
Could I ask for clarity in the work group interpretations? This is slide 77 on we recommend the intervention for individuals based on shared clinical decision making. And that's not actually what this is we're voting on. So are we actually going to be recommending the somewhat dreaded, dare I say, shared clinical decision making, which makes vaccine implementation very challenging?
So the may language, as the COVID vaccine recommendations have been made over the last couple of years, is a shared clinical decision-making recommendation. For plain language purposes, it has been worded this way, but from really from an implementation perspective, this is a shared clinical decision-making recommendation. Would any of the COVID team like to add anything to that or correct that?
No, I agree. It is a shared clinical decision-making recommendation, though we found that calling it a may, people may receive this vaccine, was more understandable. So that's what we have gone with, and it seemed to be a little bit easier in the past.
So,
Dr. Lear.
So just question for moving forward. If I'm correct in the way the process would work, is that we would now vote to decide if we want the should, and then this afternoon we would vote to decide, to actually vote on the final choice. But I've also heard Dr. Long say that she'd like some time before we decide on the vote. Did I hear that correctly?
Well, there are a lot of people running around here, and I think we're going to have some suggestions from maybe CDC folks that I would like to hear. I've been educated by Dr. Daskalakis' comments, and I wonder if there are more to come.
I was running around and missed actually a little bit of what you said. I apologize.
The lunch order? No.
So Dr. Long, do you want more time before we vote on the amendment to the resolution?
Well, we haven't heard from everyone, and I wonder if there are any other opinions. You know, I think it's very difficult to go against a work group who knows the insides and the outsides and the in-between and suddenly have a different opinion here. I think that's a very strong statement for us to do something that was not exactly the work group. Now, as Dr. Daly describes it, it sounds like the work group's hesitancy was, or was on a little different basis. I think probably we would not disagree by one of us who we would want to get a dose of this vaccine. We would want everybody who never got a dose, and we would want people who are particularly at risk to be in that critical death side to get another dose sometime. And others who might be immunocompromised, sorry, Dr. Cotton, I didn't mean to leave them out at all. So I wonder if there isn't room for two recommendations.
Dr. Wharton, if I may, just to clarify, the should recommendation from the fall for everyone to receive a single updated dose still stands. So that you know, is not being replaced by this in any way. We still want everyone to get their updated 23-24 vaccine. So this would just be for the specific group that has already been vaccinated, if they should receive an additional dose.
So that language must be in the voting language, because I would be confused as a practitioner if I saw that. It sounds like you're changing your vote to May for everybody who never got it.
Well, I think contextually we can make it clear that the intent is for persons who received the updated vaccine in the fall, that this allows or recommends an additional dose to be given at the current time. That's the intent of the recommendations. Dr. Brooks.
Yeah, I think what would inform the discussion best would be for you to go to slide 75, because that sums up the ETR 6 domains and how the work group voted after much discussion in each domain. And so the CDC, the ACIP could take a look at those 6 domains and see where it is that if you feel it should be a should, that domain is the one, well, look, that actually be a strong positive vote for. Most of the areas that we voted, there was not consensus to give an unconditional vote. I mean, probably, moderate, small, you know, so face is important, uncertainty. So this is a good way to look at it, in my opinion.
As I see the clarity of the former decision being, I would have been a should, everybody should get at least a dose of this, and a may. So this is, we're only talking about the second part. So I have a little more clarity.
Okay, thank you, Dr. Long. There's a number of members have indicated they want to speak. Dr. Chen?
Yeah, I think, well, I've really taken to heart a lot of the discussions just now, and coming into this, having seen the data, I was really struck by the fact that even though there is a waxing and waning of the burden of disease, that it really did not completely disappear. And I think it's probably lost to a lot of even clinicians that there are a significant amount of hospitalizations and deaths even at the nadir of in the summer. So it doesn't ever completely disappear. That burden of disease, seeing the risks associated with age and other underlying conditions, also motivated me to see the importance of how that second booster dose, that booster dose, could have a significant improvement in the population that receives that. So I was in favor of the change to the should. Having heard that this is really only, this vote is applicable to a very small portion of the population. We're not talking about the unvaccinated, and we're not talking about those. So I'm now stuck at actually thinking that the may language would be okay with me. However, I still want to make clear that vaccination is extremely important, and whatever we can do to improve language overall, to increase clinicians to be motivated to give a very strong recommendation to their patient population, in addition to all patients understanding the importance of vaccination, would be a goal. So, but I don't think that that's what we're voting on today. It's really only a very small segment.
Right. A minority of eligible persons received the updated dose last fall, and it's really only for that subset of the population that this would apply, who are 65 and older. Dr. Cotton?
I would just like to clarify that if we were to vote on this statement as it stands, slide 78, so if we did say should receive an additional dose of the vaccine at least 4 months later, I would want to change the language for immunocompromised to should get a second dose of vaccine, although we would need to clarify the time interval because we previously said should get at least 2 months after the first dose. So we should provide further clarity there, but I wouldn't, if we make this into a should, I wouldn't leave the other one may. Thank you.
And Dr. Cotton, if I may provide clarity on the immunocompromised intervals, it's because they can get more than one additional dose. There's a lot of flexibility built in at the discretion of the provider, but we include that minimum interval to make sure they're not getting dose on top of dose on top of dose.
Sure, and I think that there's good safety data backing that up. I will say that in my immunocompromised host community, people do not understand what the current state is, and I get a lot of questions on that. For clarity, I will say that in my own program, I have recommended that solid organ transplant recipients and other people who have moderate to severe immunocompromise get a dose of vaccine every 6 months, because clarity helps, and that will encourage vaccination. That's my own personal perspective. Thank you.
Dr. Daly?
Yeah, I'm trying to sort of integrate the I actually that was left over from before, but I think I'll take the opportunity just to jump in here. I think I'm just reflecting on the conversation here, and one thing I would add is that this would be a stronger recommendation than we made last spring, and I'm trying to think through why that is. But I just think we recognize that there's still this uncertainty. Every year that passes, we learn more, but there is this uncertainty. And I think Certainly one thing that would be persuasive to me is if there were not much disease burden over the spring and summer, but we just haven't seen that. So there is disease out there to prevent. And yeah, that is vaccine preventable. And so, but I'm still trying to reflect on why we landed on a May recommendation last spring or not. I think in terms of harms, again, I would come back to that in a way too. And I think there wasn't major concern from the work group that there would be harms in this strategy. So there was a comfort level with that. But again, there was a little bit of a, is it really needed? And if so, for whom? Sort of a difference of opinion. So I don't think this would be, going completely against the work group sentiments, but I just wanted to express that. And again, I wanted to reflect on why we landed on a May last year or not. And it was related, I think, to uncertainty about multiple aspects, also uncertainty about waning, not just epidemiology. Thank you.
Okay, well, we're going to have to deal with this amendment before we move on. So are there additional questions, discussion that would be helpful before we move to a vote on the amended language? Can we get the amended language up? Okay. So here's the amended language that replaces may with should. And so what we're voting on is the amendment. And if this amendment passes, this is the language we will take forward and vote this afternoon after public comment. If the amendment fails, we will return to the original motion that had the may language. So is everybody clear on where we are? Okay. So before we vote, there are a couple of comments from liaisons, and so let me give those folks a chance to speak before we do this. Dr. Freihofer.
This is Dr. Sandra Freihofer from the American Medical Association, speaking as a practicing physician. And I'm also a member of the COVID vaccine work group. And I found this discussion today very helpful. And one of the things that's impressed me so much is the fact that that COVID does not have the seasonality like flu, that we're still having many hospitalizations, still having many deaths as we're transitioning out of flu season. And there, as Dr. Daly said, there's still much disease to prevent. I appreciate Dr. Daskalakis' comment about the people that are against vaccines and how a should recommendation might affect them. However, a should recommendation does support vaccine confidence and our belief that this vaccine will save lives, prevent hospitalizations, prevent deaths. The other thing I worry about with the shared clinical decision-making, a May recommendation, is many people are getting these in the pharmacies, and there's still a little confusion about what the pharmacies can and cannot administer. They don't have the knowledge of a patient's medical conditions and chronic illnesses like their personal physician or provider does. So I was very impressed with Dr. Cotton and Dr. Long's comments, and it sort of changed the way I think about this voting language.
Thank you, Dr. Freihofer. Dr. Schmader?
Thank you, Dr. Ward. This is Ken Schmader with American Geriatric Society. You know, for what it's worth from the geriatrics perspective, and within the society, talking with patients and geriatricians, there's a wide variety of opinions about this that I think kind of landed towards should, but at least may. And the may business is around, there's this uncertainty about disease burden effectiveness that Dr. Daly mentioned. And there's definitely a subset of vaccine fatigue and inertia. Some of these individuals of the subset will go out right away and get it, and others will not. And another thing that's a problem is that a lot of people are thinking, well, there's going to be a vaccine in the fall. Why don't I just wait for that? So just some other things for the committee to think about. Thank you.
Thank you. Dr. Hopkins?
Thank you. This is Bob Hopkins for the National Foundation for Infectious Diseases. I think this is a very important discussion and affects many in our population. While this is important to think about this additional dose, I think it really needs to be coupled with very strong language from ACIP and from all of us to make sure that we try to get as many of those that have not yet received that first dose of the 23-24 vaccine to get that. In addition to our efforts to now better protect those 65 and older, and acknowledging Dr. Cotton's comments, that immune compromised population that again need additional protection. Thank you.
Thank you. Dr. Rockwell?
Hi, thank you. And I apologize, I wasn't present for roll call. I'm a liaison to the American Academy of Family Physicians, and speaking as a clinician and for private practice physicians, I think the stronger language of should is better here because it helps take out some of the ambiguity about the may, because I think in scholarly work and academics, we understand that. But it also helps with your electronic health record when there's best practice alerts and things like that. And I think I proposed the stronger language of should. Thank you.
Thank you. Dr. Goldman?
Thank you. I'm going to be a little contrarian, practicing internal medicine physician. I think jurisdictions have different populations that can create some contention around vaccines. So I think the May recommendation can be more effective as far as explaining the need for vaccine and the flexibility to practicing physicians in different areas. While I do think this is an effective vaccine, I think it is helpful. I think there is still vaccine preventable disease available. I think that with the issues of vaccine fatigue and the contention that this particular vaccine has created over the years, having a should vaccination recommendation may actually create other issues with getting the rest of our patients vaccinated as necessary for other recommended vaccines on the schedule. So I would suggest May, because that can at least give the flexibility for the practicing physician to be able to have the conversation with the patient and separate it from issues of other vaccines that we want them to get as well. Thank you.
Thank you. Last comment from Ms. Howell.
Yes, thank you. With long-term care residents being at high risk for severe outcomes due to COVID-19, I was just wondering if a May recommendation, would there still be a requirement for long-term cares to offer COVID-19 vaccine to their residents, or does it need to be a should recommendation for that to happen?
I think that long-term care facilities can offer the vaccine to their residents under either recommendation. And I think certainly they would fall into the high-risk category that we've laid out here that would be particularly important under a May recommendation.
Okay, are there any final questions from the committee or from any of our ex officios? And if not, we're going to vote on the motion. And the motion is the language that is currently on the screen. So I'm going to call first on our ACIP committee members and then after that on the ex officios. So we're voting on the motion. Dr. Brooks?
A point of information, we're voting on this, not the amendment.
We're voting on this as a motion, and
right.
If the motion passes, there will be a vote on this afternoon. There will be the actual vote to make a recommendation from ACIP. Right now, you're voting on what you're going to vote on.
Right, but if one is thinking that one would prefer the should language, you would vote against this. That's why I want to be.
Do you want to, is this the question you want to vote on this afternoon?
That's the only question.
Oh. I vote Oliver Brooks, no comments, no conflict, excuse me. I vote aye, yes.
Dr. Chen?
Wilbur Chen, I vote yes for should.
Dr. Sineas?
Sybil Sneas, no conflicts, should, yes.
Dr. Daly?
Daily, no conflicts, yes.
Was that a yes? Okay,
Yes.
thank you. Dr. Cotton?
Camille Cotton, no conflicts. I am happy to vote yes.
Dr. Lear?
Jamie Lair, no conflicts, yes.
Dr. Long?
Long, no conflict, yes.
Okay. Next, I'm moving on to our ex officios. Ms. Hance?
Hance, no conflicts, yes.
Dr. Kaslow?
Kaslow, no conflicts, abstain.
Commander Grimes?
Commander Grimes, no conflicts, yes.
Dr. Clark?
Matthew Clark, no conflicts, yes.
Commander Marshall?
Valerie Marshall, no conflicts, yes.
Dr. Beigel?
John Beigel, no conflicts, yes.
Okay, so the motion passes 13 to 1? No, 12 to 1, sorry. So this will be the language that will come forward for a vote this afternoon. 12 to 0. And with one abstention. So I think we have, I really appreciate everybody's good engagement on this. It was a good discussion. Thank you all for weighing in on things. And we have one, Dr. Cotton.
Just a point of clarification, let's not forget the immunocompromised and the second dose. Will we be voting on that or no?
We won't be voting on this, but we will ask the team to see what we can do within the context of clinical considerations to make guidance clearer.
Thank you.
So we have one final presentation in the COVID session. So can we get those slides up?
Okay, hi, good morning. My name is Dr. Lakshmi Panayottakopoulos, and I'm one of the co-leads for the CDC ACIP work group. Today I'll be presenting on next steps for the COVID-19 vaccine program. I will begin by discussing the question, can we improve the current COVID-19 vaccine policy timeline? In the fall 2023, the COVID-19 vaccine policy decision occurred as follows. The mRNA updated 2023-2024 formula vaccines were authorized or approved on September 11th. The ACIP met September 12th to review the available evidence for the updated COVID-19 vaccines. At the meeting, ACIP recommended the updated COVID-19 vaccines as authorized under EUA or approved by BLA in persons ages 6 months and up. Moderna and Pfizer-BioNTech vaccines were recommended for person ages 6 months and up, and the Novavax COVID-19 vaccine, which was authorized for use on October 3rd, 2023, was recommended in persons ages 12 years and older. Of note, there was a general expectation that vaccines would be widely available immediately following the recommendations. Next slide, please. Now I will go through a timeline of events following the fall 2023 COVID-19 vaccine recommendation. As I just mentioned, on September 12, 2023, there was an ACIP vote and CDC recommendation for the updated 2023-24 COVID-19 vaccine. On September 15th, the updated interim clinical considerations on the use of COVID-19 vaccines posted with the recommendation. Next slide. On September 19th, there was a COCA, or Clinician Outreach and Communication Activity Call, on the combined recommendations for influenza, COVID-19, and RSV vaccines for older adults. The timing of this COCA call had been delayed so that it could follow the COVID-19 policy decision. On September 27th, the immunization schedule was updated with the new COVID-19 recommendations. On October 3rd, the Novavax updated 2023-24 COVID-19 vaccine was authorized, and on October 10th, the MMWR on the use of the updated 2023-24 COVID vaccines was published. Next slide. However, COVID-19 related hospitalizations had already begun to increase before the ACIP vote on the use of the updated 23-24 vaccine. Furthermore, the vote and recommendation was also made only weeks before a larger increase in cases, which limited the vaccination and outreach that could be done prior to the surge. Next slide. So what happened from a programmatic perspective after the fall updated 2023-24 COVID-19 vaccine policy vote? Uncertainty around the recommendations prior to the meeting made planning for state and local vaccine programs challenging. Vaccine orders had to be placed prior to knowing the groups for whom the vaccine would be recommended. Stakeholder presentations, provider toolkits, and web pages all had to be updated after the recommendation was made, which limited the available window for communication of the recommendation prior to the respiratory virus season. There were also reports of issues with vaccine access, including among those at highest risk of severe illness. Next slide. So what are the potential impacts of continuing with the fall vote for the 2024-25 COVID-19 vaccine? There would be less lead time for planning, including staffing, scheduling, and creating electronic health record prompts for vaccination. A new recommendation could occur during a surge in COVID-19 associated hospitalizations and may not provide enough time for distribution, partner engagement, preparation of healthcare providers and facilities, and uptake to mitigate the rise in disease. This may limit the ability to coordinate messaging surrounding the fall and winter respiratory virus season and promote the importance of COVID-19 vaccination and communications, as occurred with the COCA call that was delayed in the fall of 2023. And this would likely limit the ability to plan vaccination clinics with COVID-19, flu, and/or RSV in settings such as long-term care facilities, communities, workplaces, and schools. Next slide. So how does influenza do it? This is an example of the annual seasonal influenza vaccine timeline. Every year in late February, the WHO meets to review global influenza surveillance data and make recommendations for the composition of the Northern Hemisphere influenza vaccines. In early March, the FDA VRBPAC reviews global surveillance data, discusses the WHO recommendations, and makes recommendations for the composition of U.S. licensed influenza vaccines. In late June, the proposed vaccination recommendations for the following season are presented to ACIP for vote, and around July, the FDA issues supplementary BLAs for updated antigen vaccines. Late July and early August, the start of vaccine distribution generally begins, and in late August, ACIP recommendations for the upcoming season are published in MMWR. And in September onward, vaccine distribution continues. Vaccination is recommended by the end of October, if possible, for most groups, but is recommended to continue through the season as long as influenza viruses are circulating and unexpired vaccine is available. Next slide. This slide shows the current time frame for updated COVID-19 vaccine availability with timing of the WHO TAG-COVAC recommendations and regulatory review for 2022 and 2023 shown. Generally, the WHO TAG-COVAC meets in May, followed by FDA VRBPAC in June, and ACIP has made recommendations in September. However, the current timing for the vaccine strain composition is challenging for the manufacture and distribution of vaccine early in the fall. Next slide. This slide now shows the revised timeframe for the 2024-25 COVID-19 vaccine vote and recommendation at the June meeting, allowing for more lead time between when a recommendation is made to when vaccines are manufactured and distributed. This slide shows the possibility of the WHO tag COVAX in mid to late April, followed by FDA VRBPAC in May and a potential ACIP recommendation in June. The proposed plan for 2024 would include a June ACIP meeting to review the evidence for updated COVID-19 vaccine recommendations, which includes WHO and FDA antigen selections, manufacturer studies and immunogenicity data, cumulative effectiveness and safety data, epidemiology from current and prior years, uptake from current and prior years, and cost effectiveness. ACIP would then vote on the updated COVID-19 vaccine recommendations in June, and the 2024-25 formula will become available as regulatory actions are taken by the FDA and vaccines are distributed by manufacturers. Next slide. Sorry, next slide. So what are the pros and cons of a June COVID-19 vaccine policy decision? Next slide. One of the biggest benefits of a June COVID-19 vaccine policy decision is that it enables early planning across the entirety of the healthcare delivery system, including national, state, and local public health departments, large and small practices, and other venues for vaccine delivery, such as pharmacies. Another benefit is that it allows time for clear communication of recommendations. It also provides vaccine sites with earlier information on which to base vaccine ordering decisions. Vaccines can potentially become available immediately following FDA authorization or approval. COVID-19 vaccine recommendations can align with influenza vaccine recommendations, and this can lead to a decrease in the number of emergency ACIP meetings. Next slide. There are also some potential cons of a June COVID-19 policy decision, although it is important to note that ACIP does not make recommendations on vaccine composition. With regards to epidemiology and strain changes, minor changes in circulating SARS-CoV-2 are unlikely to impact a recommendation in June. That is, the recommendation made in June will still be applicable following a minor change in the virus. Major changes, however, may require subsequent emergency action, which is always the case with an evolving virus. Of note, the updated vaccine antigen changes do not require new human data. Manufacturers provide preclinical immunogenicity data to the FDA for VRBPAC antigen selection. Additional clinical trial data beyond that presented at VRBPAC may not be available before ACIP votes, whether in June or September. The decision would largely rely on the large body of cumulative effectiveness and safety data from previous formulations. And finally, consistent temporal patterns of COVID-19 have not yet been established. And while this is true, we do have over 4 years' worth of epidemiologic data to predict a peak in the winter of 2024-2025. Next slide. So what can we take away? We have over 4 years' worth of data on COVID-19 and over 3 years' worth of data on COVID-19 vaccines. We have a well-established precedent from the influenza vaccine recommendations. The influenza virus also evolves rapidly and requires updates to vaccine antigens. It is unlikely there will be more data between June and September that would influence the updated COVID-19 vaccine policy decision. The increased lead time will ease implementation challenges for vaccine providers, including earlier information on vaccine recommendations to inform ordering, allowing providers to recommend the vaccine in anticipation of availability, training staff to counsel patients who are making appointments for influenza vaccine, and allowing providers and public time to make informed decisions. The increased lead time can also allow for clearer messaging in provider and patient educational materials. Next slide. This plan was presented to the COVID-19 ACIP workgroup. It was noted that it's important to separate out the policy question and decision from the timing of the decision. Workgroup members were in favor of moving the decision to June and discussed many ways that this could ease implementation challenges, including clearer communication of vaccine policy and increased lead time for clinicians. Workgroup members emphasize that communication surrounding a recommendation prior to vaccine availability, as done routinely for influenza vaccine, will be important. Next slide. And now I'd like to thank the following people for their contributions, and I'm happy to take any questions.
Thank you. Are there any questions on this presentation? Dr. Chen.
Yep, two questions, I guess, that are maybe tangential to what you've presented for the policy implications. One is understanding how the Bridge Access Program has had an effect on implementation and uptake, and also is there an update on the move toward beyond the Bridge Access Program and the vaccines for adults? And then the second thing is a different question, which is, do we have more data that we'll have on concomitant administration of vaccines, COVID, influenza, and RSV vaccines? Because I think the lack of data has been a barrier in trying to communicate our confidence with these vaccines and trying to accomplish it all in a single visit. So I think it would be an advantage to have more of these data available so that we can have that confidence at that visit and communicate that. So two different questions. One is bridge access and the other one is concomitant administration.
Hey, Kevin Stevens here from Immunization Services Division. So yeah, in terms of this shift, the Bridge Access Program folks have definitely been tracking these discussions. And I think, as has been stated, any additional lead time will help with any transition to an updated vaccine for the next season. So they're aware of it and they're taking these discussions into their plans. Did that address your question?
I know that there's a good deal of work going on the simultaneous administration issue. I don't know if Dr. Wallace, could you or someone else from your team comment on that?
Yes, thanks. So simultaneous administration is still part of general best practice, and so particularly, with the COVID vaccines, there's no concerns with administering it with flu or RSV or others, and so we're always looking at it and gathering new information, but that still continues to be general best practices, and there's no concerns with that.
Are there Dr. Long?
So I think the June decision sounds like a good one. Marrying it to what doctors anticipate now hearing about influenza is a good decision. I'm just a little confused about what the vote in June will be. Will it be to recommend a dose for universally for 65 and older? Or will it be strain selection?
So strain selection is done by FDA, and their advisory committee will be weighing in on that. And I believe the date for that was just announced. Is that correct, Dr. Kaslow? So that is not a decision that we ask ACIP to weigh in on. And I don't know exactly when the decision will be made by FDA following the VRPAC meeting, but I would expect it would likely be made before the ACIP meeting in June. Do you want to add anything to that?
No, David Kaslow here. Yes, that's correct. And this year, the ACIP, the VRPAC meeting is scheduled for the 16th of May.
So this will be a decision that we will or will not recommend vaccine for certain groups of people?
Yes, the expectation is that in June, the work group will have a proposal for the committee on proposed use of COVID-19 vaccines in the fall. And I do not know what that proposal will be. I'm not sure I'm not sure how far along they are on that, but that is our expectation for June.
I see. So there's not necessarily an expectation. I'm just thinking about what we're going to vote on this afternoon. If everybody 65 and older or 70 and older gets the vaccine now, because it's been 4 months since October for sure, or September, October when most people got it, then what would the cost effectiveness look like if we 6 months later suggested that they all get it again. I just don't understand this little window of less than 4 months that we're recommending something when it's pretty low right now. We're about 10% of specimens in Philadelphia that are positive for coronavirus right now, 19. Why we're doing this very short-term thing when we're looking for a longer-term thing in less than 4 months?
Well, of course, the updated vaccine, assuming that there is an updated vaccine for 2024, 2025, that vaccine will not be available until fall. So it's actually a number of months away, even though we'll be discussing it in June.
Yeah, Dr. Elling, I appreciate the sort of call for clarification and distinction between those, and there were work group members who brought up that exact thing, which is what happens in June of 24, right? And sort of what should I get, what applies to me, and really we think of influenza vaccination as a seasonal thing, and vaccination stops. You know, when I was training, it would stop in December, but now we vaccinate all the way through typically March for influenza. But for COVID, our strategy is different. And so if somebody came in June and had not received a 23-24 vaccine, they would still be eligible. The vaccines would not be expired, and they could get that. I just think the likelihood of that happening, given that they've had 9 months of opportunity, probably goes down and down and down, but it doesn't go down to zero. But the vote this afternoon is distinctly different. It's for now, and it's for a particular high-risk group. They're high risk by virtue of age. This is an anecdote, but you know, I work in a large health system, and I've started getting emails from providers or patients saying, I'm 71, and I've got some chronic conditions, and I have a trip coming up or a graduation or a something, and I'm worried, can I get another dose now? And what I had to say, this was just an email from yesterday, and I had to say, well, just wait a day or two, right? Well, and it was somebody who didn't know I was on this committee, but I just said, I think there may be some news on that. But that's for now. And then we make a fresh decision about next year with an updated vaccine. And that decision is informed by what we learned this past season, what we learned about safety, what we learned about effectiveness, what we learned about barriers, what we learned about attitudes. It's informed by that, but it is sort of a fresh start. So what I imagine is that in June, we're gonna say, here's who we think should get a 24-25 vaccine in the fall. And we'll say, here's who we think should get. And we, the work group, will present that for the committee, but I don't think that we should, if we think there's benefit to over 65 getting an additional dose now, that we should postpone the decision. And those are different decisions for in different circumstances, different populations. But I had a question and a comment. I'll make the comment first, and then my question is for Dr. Kaslow. But the comment is that the work group was unanimous that there were so many benefits of making a June decision. You know, people recognize that there are some risks given unknown epidemiology, et cetera, but there was so much consensus that there were so many benefits to making this decision earlier. My question for Dr. Kaslow is just sort of whether this quote unquote makes sense from the FDA perspective. Thank you.
So please define what this is when you say, does this make sense?
I'm sorry. ACI planning to make a recommendation for who should receive a 24-25 vaccine at a June meeting.
Yes, it does.
And thank you, Dr. Daly, for your clear explanation of how today's vote interacts with the June vote, which interacts with what we're going to be doing in the fall. You explained it much better than I did. Are there any other questions or comments on this topic? I think we do have a question or a hand up from what liaison representative, Ms. Coyle, did you want to ask a question or make a comment?
Thank you. Yes, I appreciate the recognition. And I think my comment is primarily related to the timing of when all of these events happen and just acknowledging that the role of health IT systems, so whether that be an electronic health record system, a pharmacy system, or an IIS, some of these codes will have to be developed, and being able to get those out and updated in systems does take a little bit of time. So any consideration for, one, just acknowledging that this needs to occur in that same time frame, but then also building as much time in there as possible to ensure that as many systems can update these before vaccine administration is greatly appreciated. Thank you.
So lengthening that lead time between recommendations and vaccine administration is helpful.
The time between the recommendations and specifically the licensure. So once we know what things are going to happen, making sure that we can get that in as quickly as possible.
Okay. Thank you for bringing that issue up. Are there any other additional comments? If not, I want to thank all of the presenters in the COVID-19 vaccine session for really excellent presentations. Thank the committee for great engagement on the topic. And I think we are running a few minutes late, but we will take a break till 20 after. We'll take a 10-minute break, and so we'll see you back at 11:20 Eastern, if you're on the Eastern time zone.